Hello everyone, our next session is lined up, but I would like to welcome once again all of you in India's biggest medical PG prep academic event, the DAMS Visual Treat 2023. Let me also thank you all for being here, and also let me congratulate you for being a part of this academic extravaganza called DAMS DVT 2023. We are certain that all of you out there are benefited by the valuable inputs by our honored speakers. And let's remember that apna time apun khud laega. I have the honor of welcoming our next speaker, who has a dynamic personality, a versatile genius, I would say. With so many achievements to his credit, it is impossible to describe him in words. His life is an inspiration for us all. With so many roles like being a doctor, entrepreneur, blogger, motivator, 3 times TED speaker, a motivator, whew, this is simply incredible. Well, no points for guessing it right. Let us welcome Dr. Sumer K. Sethi in his radiology session. Dr. Sumer K. Sethi, who is lovingly called as Sumer Sir, has given hope to millions of young doctors worldwide. And as it is customary, I give a brief about his background. Dr. Sumer is an MBBS graduate from Maulana Azad Medical College, MD Radiology from LHMC New Delhi. He is a senior consultant radiologist with over 2 decades of experience. And last but not the least, the founder of DAMS eMedicals. We welcome you, sir, in your radiology session. Over to you.
Hanji, very good morning everybody, good morning, and I am super excited, supercharged to be here with all of you today. And our goal today will be to cover radiology in a very conceptual manner. Okay, so are you ready for your DAMS DVT day 2? Are you ready with your pens and your copies and a lot of motivation and coffees? Okay, so let's start the first discussion of the day. Are you ready? Okay, let me know in the chat box. We have a record attendance on the app and in the auditorium, and I'm sure if we were able to do a Guinness record, it would have been the largest concurrent medical classroom ever done in India, where everybody is attending it together. Hats off. Okay. So, what have we done so far in the classes? What have we achieved so far in the classes? I will tell you. So far in the classes, I have given you knowledge. You have multiple knowledge, and all this knowledge is scattered as points. And somehow, we need to connect them into a resource which can be revised multiple times. We need to connect them with experience. That is what your teachers bring to the table. They are able to connect the dots with experience. But today I will go to the next level. Today I will not only connect the dots with experience, I will connect the dots with creativity. And when you connect them with creativity, you are able to see something that others could not even imagine. So what we are going to do is, I am going to use a superpower that is there in your brain called as imagination. We will not use memory, understanding. No, we will use imagination today. Okay, are you ready to imagine and learn with creativity? And let us try to do radiology together. Okay, the first thing, okay, I want all of you to look at this image and tell me what is happening in this image. I want all of you to look at this image and tell me what is happening. This is an image showing you a process of inflammation. Now, what is inflammation? Inflammation is a response of our body to an attack. Now, suppose you have an infection in your brain, our body will respond with inflammation. And the inflammation, everybody listen to me, suppose this is an attack on my brain, I should have inflammation all around. Now, I cannot make a square around it, I will make a circle around the enemy. Okay, any place where you have inflammation, you will have increased blood flow or hyperemia. So I want all of you to tell me in the chat box. Imagine, don't understand, don't memorize. Imagine, tell me. Suppose this is a bacteria in my brain. Surrounding it, you will have inflammation, a ring of inflammation. Why ring? Because in real life, you need curves. You don't need straight lines. Now tell me, if I give contrast, what will you see? If I give contrast, what will you see? You will see a ring of dye uptake around the disease. Okay? Are you ready? Are you ready? Okay. Now let's see the first image. So now once we have been able to imagine, I want you to see the first image. Can you see this area on this MRI and describe the pattern? Can you describe the pattern for me? What is it that you can see here? You can see a ring-like enhancement. If you see ring enhancement, that tells me there is probably an infection with an inflammatory response around it. So what do you see on the screen? So we can see on the screen, look at the arrow, you can see a ring enhancing lesion. Okay, are you able to see it? You can see a ring enhancing lesion. And already I know by my discussion that this ring enhancing lesion is probably an infection. Can you think of some infections of the brain? NCC, tuberculoma, toxoplasma, brain abscess. But if you notice, these are all either parasitic or bacterial. They are not viral, because a viral infection would be more intracellular. It will cause intracellular inclusions. It may not induce the same inflammatory response. So whenever they ask you in the question, which of the following is a cause of ring enhancing lesion, you will mark NCC, tuberculoma, toxoplasma, brain abscess. But don't forget the masquerade. Sometimes you may have a patient with a metastasis which is by chance looking like a ring lesion. So don't forget, although ring lesion is always an infection, but there is an exception called as metastasis. Okay, there is an exception called as metastasis. Are you okay with this? Okay. Okay. So once you are able to do this, let us look at the second concept. Okay. I want all of you to imagine and tell me what is happening. Okay. Now I am going to show you one more image where you have one multiple ring enhancing lesion. Why would you have multiple ring enhancing lesions? Multiple means they must be spreading via blood. That means there must be hematogenous dissemination. Okay. So there is some infection which is hematogenously spread. Okay. Now my question to you is this. If this is an infection, why the lesions are conglomerate? That means this infection has the probability of causing coalescence. This infection is probably tubercular. So there are multiple ring enhancing lesions. Ring enhancing lesions are infections. If they are conglomerate, we think of anyone? Yes, almost all of you are able to answer tuberculoma. Then we think of tuberculoma. Are you able to do it? Okay, done. So far we have seen that ring lesion means infection. And if the ring lesion is conglomerate, it is tuberculoma. Now, can anyone in the chat box tell me, why is the center of the ring lesion in tuberculosis not enhancing? Can anyone in the chat box tell me, why is the center of the lesion not enhancing? Anyone? Because the center in TB is usually necrotic. The center will have necrosis. Okay. And now we know by now, in brain, listen to me everybody carefully and try to imagine. In brain, all the lipid that you have is bound to myelin. All the lipid that we have in brain is bound to myelin. We don't have free lipid. But in necrotic tissue, you have lipid. So imagine now if I do a MR spectroscopy and I want all of you to look at this image. What is it? Tell me, what do you see? Please tell me, put the chat box on fire. You see lipid. If you see lipid peak on spectroscopy, that means we are dealing with, tell me, we are dealing with necrosis. Which infection will have necrosis? Tuberculosis. So the likely cause will become tuberculoma. Lipid peak on MR spectroscopy indicates tuberculoma. Okay, are you able to do it? Okay, very good. So we are trying to go step by step looking at an infection and how the inflammation responds and how we look at it. Let's look at another image. Okay, let's look at another image. I want all of you now to imagine a tubercular focus hematogenously from the lung. TB starts in the lung, hematogenously goes to the brain. And one of the tubercular focus goes to the subpial region of the brain. Okay, imagine a tubercular focus hematogenously goes to the subpial area in the brain. Okay, everybody. Now, if that is called as Rick's focus, we use the term Rick's focus. This subpial focus can rupture into the meninges. Now, my question to all of you is, if an infection spreads to the meninges, always there will be an inflammatory response and inflammation will be labeled as itis. What will you call it? You will call it tubercular meningitis. You will call it tubercular meningitis. Are you clear? Now I have a question for all of you. Let's see if you can answer in the chat box. Don't think, try to answer with imagination. If there is inflammation in your meninges, okay, the capillaries will leak and form fluid. What kind of fluid? Will it be transudate? Will it be exudate? What kind of fluid? It will be exudate. Tubercular exudates are heavier. So instead of settling on the top of the brain, they tend to settle down at the base of the brain, around the brain stem, in the interpeduncular fossa. You will see the exudates will settle in the base of the brain. Okay, done. Now tell me. So now what will be the key word if you are dealing with tubercular meningitis in the exam? The key word for tubercular meningitis will be basal exudates. Are you able to now feel the term? Imagine, remember forever in your life. Now I want you to see, listen to me here. I want you to see this area, beta. Everybody look at me. Okay, stop writing, look at me. I will upload all these slides also below your video later on, just like the previous classes. So focus on understanding and imagining, beta. Please see. This is your midbrain. In front of the midbrain, you have the interpeduncular fossa. Interpeduncular fossa should be full of CSF. But if you have inflammatory material in the basal cisterns, it will show contrast enhancement. Are you able to see in front of the midbrain, around the midbrain, this white area? This enhancement is called as basal exudates. This is called as basal exudates. Are you clear? Now, listen to me, beta. This is the area of the interpeduncular fossa. In this area, you have the circle of Willis. I want all of you to imagine and tell me, if this is your blood vessel, in TB around the blood vessel, you have inflammatory material. What will happen to the blood vessel? Tell me. In TB, around the blood vessel, you will have, tell me, inflammation. So that will lead to inflammation of the artery. Inflammation of the artery will be called as arteritis. Brain arteries are end arteries. That is called as endarteritis. That will lead to infarct. That leads us to a previous NEET PG question. Which meningitis is associated with brain infarct? The answer is tubercular meningitis. These exudates at the base of the brain can also obstruct the CSF pathway. Can you tell me, if the CSF pathway is obstructed, you can also develop? Can you tell me now? Hydrocephalus. You will develop hydrocephalus. Very, very important question. This is the three features. If you see, you will make a diagnosis of tubercular meningitis. And I am marking all the findings with the arrows also, so don't panic. Okay. This enhancement that you see in the basal cisterns is called as basal exudates. Okay. So far, all I'm talking about is inflammation, hyperemia, how it looks like, exudates, fluid collections. Okay. Now I'm giving you a clinical situation. A patient comes to you with ear discharge. Why would you have discharge from the ear? Infection in the ear. Sinusitis, itis, infection in the sinus. Or tetralogy of Fallot. Let us look at the situation one by one. Okay. Ear discharge, you have a source of infection in the ear, sinus. If this infection goes into the brain, what will happen? If this infection goes into the brain, what will happen? Try to hear me out and imagine. Any infection which goes to the brain or our body, any body part, we will try to fight with inflammation. But here the fight will go on for a long time because we have a reservoir for infection. Infection from the ear will supply the bacteria again and again, and in the inflammation in the center you will have a graveyard of dead WBCs and dead bacteria, which is called as pus. So always remember, if you have an infection in a body part with a second reservoir, it is likely that it will lead to abscess formation. You might not believe me right now, but remember now, if you have infection in the cecum with amoeba, entamoeba, and it goes to the liver, there is a reservoir in the cecum. So you will develop liver abscess because the infection will go on, the battle will go on for a long time, there will be pus collection. So people with CSOM, sinusitis, tend to develop a brain abscess if they show a ring lesion. What about tetralogy of Fallot? What about tetralogy of Fallot? Infection is an attack on our body. Infection is an attack on our body. But all our body, we are protected by skin. Imagine some infection happening in the skin. It might enter the vein. Suppose you are not supposed to be. Suppose someone is an IV drug abuser. Then what will happen? The infection can go into your vein. From the vein, the infection can go into your right heart. Then it goes to the lung, causes septic emboli. It is cavities. It will be filtered by the lung. But imagine somebody with a right to left shunt. Infection can go from the right heart to the left heart and go into the brain. That is called as paradox embolism that is happening. So people in TOF can also have a brain abscess formation. Okay, now look at it. Everybody now. Now if the history was ear discharge, sinusitis, cyanotic heart disease, and they show this in the exam just like a previous NEET PG exam, what do you see? Forget about everything that you've learned so far. Imagine with me. Imagination is your superpower. It is not memory. Memory is for average people, understanding above average, imagination for legends. And you are a legend. Okay, listen to me everybody. Do you see a ring enhancing lesion? Inflammation surrounding it. Liquid is in the center. That is pus. Always think of brain abscess. Always think of brain abscess. Okay. History. Ring lesion. Liquid in the center. Inflammatory rim. Think of brain abscess. And I am sure already you know these are the kind of questions that you keep getting in your exam. But I will take you a level higher. I will also cover a little bit of ideas for your central exams also, because I know many of you will not stop at NEET PG. Promise and tell me in the chat box. Many of you will appear for the May inicet also. All my bachas, all the damsonians will definitely do it, because by the time NEET PG result comes, you should be actually appearing for the May exam. Are you ready with it also? Okay. Clear? Okay. This is the frontal lobe abscess. Yes. Very good. Very good, Madhurima. Okay. Now please see. in Central Institute, they take things to the next level. Pus in any part of our body, if you have pus will be thick and viscous. Pus will be thick and viscous. Now tell me, if you do a diffusion weighted MRI, which can show you particle motion, there will be no motion in the pus because it is thick and viscous. So always remember, brain abscess shows bright signal on diffusion weighted MRI. Brain abscess shows bright signal on diffusion weighted MRI. Why? Because pus is a thick viscous material. I'm sure you have seen pus by now. Yes? You remember all those, pimple that you pus, thick, viscous, no particle motion, bright on diffusion weighted MRI. Possible question in the Central Institutes. Ready? Okay. Okay. Next question. Okay. Next question now. Now, inflammation is a response of our body to an attack. My question to all of you is, what if there is no attack? What if there is no attack, but the spies in our body fool us and we launch an attack, inflammation against our own tissue? That is called as autoimmune disease. Let us try to see one by one. Okay. I want all of you to look at this MRI. Can you look at this MRI? Look at the color of the CSF. What is the color of the CSF in this image? White. Why? This is a T2 weighted image. T2 weighted images are best suited for pathology assessment. T2 weighted images are best suited for pathology assessment. Okay. Now please see. So what are these? Everybody see the arrows. What are these areas? Pathologies in the white matter of your brain. Can you see multiple diseases? Okay. Let us give IV contrast to this patient. Let us give IV contrast to this patient. What do you see? There are some of the lesions which are showing contrast enhancement. Okay. There are some of the lesions which are showing contrast enhancement. Okay, everyone, I am sure you can tell me. I am sure you can tell me, beta. Why not all? Why not all? Why not all? That means only these ones are having increased vascularity. They have hyperemia. That tells me that these are the ones which are actively inflamed. What about others? That means this patient had a chronic neurological disease in the white matter with a relapse. This is the acute disease. This is the older disease also. That tells me this patient has a chronic relapsing remitting neurological disorder. Or if I use a term, this disease is disseminated in time. समय के चक्र में ये फैलाव है. इसे कहते हैं dissemination in time. That tells me probably I am dealing with a disease which is more chronic with the relapsing remitting course. And I also see there is a disease in the spinal cord also. If you see a disease in the spinal cord also, that tells me that it is a multi-compartment disease. It is disseminated in space and time. Can you name the disease? Disseminated in space and time. So what I wanted to tell you and impress you is, not every time you see an inflammatory lesion, it will be infection. It could be an autoimmune phenomena. Demyelinating central nervous system phenomena called as multiple sclerosis. This multiple sclerosis, everybody hear me out, I want you to imagine with me. Think of it that I'm telling you a story of pathogenesis of radiology today in the class. Once you know this, I am telling you, here onwards in your life, you will find yourself more confident in radiology. Now, please look at it and understand. Multiple sclerosis has predication for perivenular tissue. Multiple sclerosis has predication for area around the veins. These veins are arranged perpendicular to the ventricle. So what will happen is, In multiple sclerosis, you will see finger-like areas of demyelination perpendicular to the ventricle. Can you name them? Can you name them? Yes, the answer will be Dawson's fingers. Possible question, previous NEET PG question as well. Dawson's fingers are seen in multiple sclerosis. Are you able to do it now? Okay. One bacha saying, what is CEMR? CEMR was the contrast enhanced MRI. In MRI, when we give dye, we use gadolinium, that is called as contrast enhanced MRI. Apurva. Okay, done? Okay, let's look forward now. If the same patient with multiple sclerosis comes to you with loss of vision, multiple sclerosis, painful eye movement. Now I have to suspect that the same inflammation that was happening in the brain has also happened in the optic nerve. That is called as optic neuritis. Now if I do a contrast MRI, can you see now this optic nerve? Look at the red arrow, beta. Look at the red arrow. The optic nerve marked by the red arrow is enhancing more than the left side. That tells me there is inflammation of the optic nerve. Any inflammation will be written as itis. The answer becomes optic neuritis. How will you diagnose it? We need to use a contrast MRI. To see the inflammation, we need to give IV contrast, because inflammation has a cardinal hallmark called as hyperemia. Okay, clear? Okay, now let's take you a level ahead. We are looking at inflammation, we are looking at brain diseases. Let's change the body part. Okay, I'm changing it to lungs. Imagine you have a bacterial infection like strep pneumoniae or Klebsiella, any bacterial infection in your lower respiratory tract. So the bacteria are able to reach to this level. They have come into your alveolar area, into lower respiratory tract. What will the capillaries do? Surrounding your alveoli, you have capillaries. Surrounding the alveoli, you have capillaries. Why? Because they were doing blood gas exchange. Okay. Now my questions are same to again and again. Please answer, beta. If you have bacteria in the alveoli, capillaries will leak, exudative fluid will go into the alveoli. Alveoli are interconnected through pores of corn. So the inflammatory exudates will be collecting in the entire lobe in the alveoli. Okay. So if your alveoli are filled up with inflammatory exudates, okay, they will appear white on the X-ray. But the bronchus will not be filled up with inflammatory material. It is only the alveoli. So I want you to look at this area. Can you see this air-filled bronchi? This is the most basic X-ray that you can learn in your MBBS. Anyone can tell me in the chat box, what is it? What is it? Tell me. The X-ray shows a sign called as air bronchogram, which is also a characteristic size. Bhai, if you are becoming a doctor and you mess it up, sahi nahi hai bhai, pneumonia, consolidation. Then if you see air bronchogram, opacity, think of consolidation. But did you realize I have not talked of anything big? I'm only showing you different body parts responding to infections. Once we see it, we realize the beauty of the world. We realize how we are constantly under attack from the organisms, how we are responding, and sometimes we respond to wrongly, that is autoimmune. How beautiful the entire concept is going on. Okay, now let's go to the next level. I want all of you now to look at this X-ray. Try looking at this X-ray without me. When you look at this X-ray, what do you see? Now this X-ray looks like the lungs are more dirty. Let me zoom it. Now see, can you see in the lung parenchyma on both the sides, you have net-like opacities. You have opacities which are shaped like a net. What do you think? These are what are called as reticular opacities. These are called as रेटिकुलर ओपेसिटीज, नेट लाइक, ये मिलरी नहीं है, मिलरी डॉट 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 होगा, ये नेट के जैसा है, नेट लाइक रेटिकुलर ओपेसिटीज. नाउ इफ यू सी रेटिकुलर पैटर्न, एनीवन, if you see reticular pattern, then what does it mean? It tells you that the inflammatory process or the disease that is going on is in the interstitium. It tells you that the inflammatory cells are seen in the walls of the alveoli in the interstitial tissue. Okay. So whenever you see reticular pattern on the chest X-ray, we think of interstitial disease. Like if it is a fever patient, we think of viral pneumonias, mycoplasma pneumonia. If it is HIV patient, we think of pneumocystis pneumonia. If it is a mine worker, we think of pneumoconiosis. Okay. Reticular opacity tells you that there is disease in the interstitium. But X-ray cannot tell you the severity. To see and characterize the interstitial lung disease, we need to do a HRCT. Then we need to do a high resolution CT. Okay, everybody done? Okay. Okay, now let's go further. Okay. Now, no class of infection can be finished till the time I mention this infection. I want you to hear me out. Normally, if you have a viral infection, in the lungs, you should see interstitial infiltrates, interstitial inflammation, interstitial. But what if that is a new virus? What if it is a virus that the world had not known before? Then that viral infection will cause some alveolar cell damage also. And your alveoli will be partially filled up with inflammatory fluid. Now answer my question. Normally, if the alveoli are fully filled up fluid, they cause consolidation. But if the alveoli are partially full of fluid, you will see these. These are, you know this in 2020, these are ground glass opacities, multiple peripheral ground glass opacities seen in COVID pneumonia. So always keep in mind that sometimes they may ask you something very simple and you were studying too much. So I am only betting on the usual concepts that a doctor is supposed to know at MBBS level. Okay, this is all my creation. The entire of the story that I'll tell you today is my creation and my vision, how a concept should be in your end. What should be your concept of radiology? Now, why are these ground glass? Tell me. Because they are not as white as a pneumonia would be, but they are not black. In between ground glass opacities. You think of COVID. Now, when we were having COVID patients, we were using a nomenclature called as CORADs. We were using a nomenclature called as CORADs. Anyone? I'm asking you a question. Tell me in the chat box. CORADs tells you the severity of the disease. Yes or no? CORADs tells you the severity of COVID. Yes or no? Answer is no. CORADs only tells you the level of suspicion. It does not tell you severity. Only level of suspicion. Okay. If the CT scan is normal, CORADs 1. If the CT scan shows an infection other than COVID, 2. Okay. If the CT scan is normal, CORADs 1. If it is infection but not COVID, 2. If the CT scan shows typical COVID, then this is a previous question, previous NEET PG question. Now tell me, typical COVID, CORADs 5. RT-PCR positive, CORADs 6. Are you able to do it? CORADs is based on CT scan in a patient with suspected COVID. Okay, CT scan finding in suspected COVID. Okay, done? Okay. Now let's go forward and look at what are the usual findings of COVID pneumonia. What are the usual findings of COVID pneumonia? Multiple ground glass opacity, which are peripheral and basal. Okay. Okay. Some people are saying कि sir CORADs बाकी भी बता दो. यही पूछेंगे, जो मैं बता रहा हूं वही पूछेंगे भाई, उसके अलावा वाले करने ही नहीं है आपने. ओके, सो ट्राई टू अंडरस्टैंड. आई एम ट्राइंग टू टेल यू व्हाट इज गोइंग टू बी आस्क्ड इन द एग्जाम. Don't reply to ask me another question. Listen to understand what I am selling. Okay, because what is happening is Corat 4, they will never ask, it is ambiguous, so they will not ask undergraduate. Many people don't know this. What I am telling you is what they will ask you in the exam. They will ask you, this is a previous FMGE question, what is the most common finding in COVID pneumonia? Peripheral basal ground glass opacity. These ground glass opacity should have round shape. What other findings are possible? Crazy pavement, reverse halo, spider web, ground glass plus consolidation. Ground glass plus consolidation. Okay. But to make a question, I need to know what are atypical findings which are not seen in COVID. Atypical findings of COVID are, let me just get back to the slide. Okay. Central distribution and apical. So peripheral basal is typical, central and apical will be atypical. Lymph node enlargement, cavitation, tree in bud, nodular pattern, mass, pleural thickening, calcification are atypical in COVID. Lymphadenopathy, cavitation, tree in bud, nodular pattern, mass-like pattern, pleural thickening, calcification are atypical. Now, I am sure if you appreciate, think like an examiner. The examiner will put 3 of these and 1 of this in the choice. Okay? These are not seen, these are seen. They will ask you which of the following is seen in COVID or which of the following is not seen in COVID. Are you able to understand this? Okay. Round shape. Selma is asked round shape. But a round shape of the opacity. Ground glass opacity का shape round होना ज़्यादा typical है COVID का as compared to कोई और shape. Okay. So I'm sure, I always want my students to have curiosity. Common diseases you need to know. I don't know today because of the plethora of useless material floating around on YouTube. Many people are just following YouTube, but missing out on COVID, tuberculosis, HIV. In the exam, they will have a problem. Please understand. Don't miss out on what I'm telling. Common diseases are always asked. Okay? Okay. Now let's see next question. Now I want all of you, everybody, wake up, it's morning. Now look at this area. Can you see a ring-like area? A ring-like area? That tells you there is some inflammation. That kind of inflammation in the lung would be seen as a cavity. So there is some kind of inflammatory response looking like a ring. But do you see a symmetry? Just like brain, inflammation core like a ring. But if you have a dental infection, there is a reservoir of infection and you are aspirating and the infection is going into the lung again and again, and you form pus inside it. On a chest x-ray, because it is an erect x-ray, the pus or the liquid will go down, air will go up, you will see a air fluid level. Now, tell me, do you see an inflammatory lesion? Yes, it looks like a ring. Do you see pus inside? Yes. What do you think? What is your answer? You can see a lung abscess. So, we have seen a brain abscess, we have seen a lung abscess. Only thing abscess means is inflammation with pus inside. Once you know it, the body part does not matter. It is about imagining the system, imagining the pathogenesis. Once you know it, everything falls into place. Any doctor who doesn't know approach to infections, you will struggle because most important patient will come to you will be fever. Okay, never miss out on it. Okay, let's see, change the body part again. Let's change the body part again. This is, okay, everybody look at me. This is your liver, gallbladder, inferior vena cava, aorta, pancreas, left kidney, spleen. Okay. I am trying to show you a normal CT abdomen so that I can show you inflammation. My question to you is, everybody listen to me. Suppose somebody has gallstone disease or alcoholic. These people can develop inflammation in the pancreas. That is called as pancreatitis. If the inflammation is severe, it will also cause damage to the normal tissue, that is called as necrosis. I want you to look at this now. Please compare this pancreas with, okay, look at this pancreas, beta. Tail of pancreas, body of pancreas. Please see this pancreas and tell me, I'm sure you can look at this. Okay, everybody on the screen, beta, and look at this pancreas now. What do you feel? What has happened to the pancreas? It is swollen, and that is when you will think in the exam, inflammation. You will say itis, acute pancreatitis. And I am so surprised that nobody noticed that every inflammation would look like inflammation, abscess would look like abscess. The body parts actually don't matter. Now my question is, if, listen to me everybody, listen to me. If because of inflammation, the pancreatic enzymes are leaked, they cause necrosis of the parenchyma. Necrotic tissue will not enhance. Look at this white arrow and tell me, what is this? Necrosis. So there is necrotizing acute pancreatitis in this patient. This is a previous inicet question. Necrotizing acute pancreatitis in front of you. Okay, now let us do some question. Let us do some question. What is your diagnosis? Pancreatitis. Okay. Now, what is the radiological investigation that you do in these patients? In acute pancreatitis, the investigation that we do is CECT, contrast enhanced CT. In your exam, they will ask you, when do you do a CT? And why do you do a CT in pancreatitis? In pancreatitis, we do a CECT after 72 hours. After 72 hours, okay? And all of you, tell me why? Why? For diagnosing or for severity? What is your goal? Diagnosing, severity? Anyone? I want to see the severity. Previous NEET PG question also. Most important reason for doing a CT scan in pancreatitis is severity. Most important reason, severity. Very good. Now, anytime you have inflammation, inflammation will cause capillaries to leak. If the capillaries leak, you will develop fluid collection. You will develop fluid collection. This fluid collection, less than 4 weeks, will be ill-defined. More than 4 weeks will become well-defined. It will become walled off. If you have interstitial pancreatitis, and you see fluid collection, in the first 4 weeks, you will call it acute peripancreatic collection. After 4 weeks, remember the word 4 weeks, possible question for your NEET PG, you will call it pseudocyst. Because it is not lined by the epithelium, it is a pseudocyst. Remember, fluid collection seen in interstitial pancreatitis after 4 weeks will be called as pseudocyst. Okay. Now, what about necrotizing pancreatitis? Necrotizing pancreatitis, the fluid is also having a lot of necrotic tissue. So, less than 4 weeks, we will call it acute necrotic collection. Acute necrotic collection. More than 4 weeks, we will call it, possible question for the NEET PG, walled off necrosis. Walled off necrosis. Okay. Done? Okay. So, let's look at another inflammatory cause. Now, we change the body part to liver. This is your liver. Anyone? Liver. I want you all to look at the disease in the liver. Do you see the same ring-like enhancement? Do you see the same ring-like enhancement? Infection, inflammation, infection. But my question to you is, what is in the center? You see a lot of liquid. What liquid will be present in the center of inflammation? Dead WBC, dead bacteria, that is called as pus. Make a diagnosis. Previous NEET PG image. Make a diagnosis. Abscess, 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 abscess. Yes, liver abscess. Now, to your surprise, the abscess looks like an abscess. It doesn't matter if it is in the brain, lung, or liver, any body part. Once we know what the abscess is, it makes sense. All we need to do is build imagination. The entire problem is we are being fed with so much information which is ready-made. We have stopped imagining. Okay? So now we start to imagine the diagnosis will become liver abscess. Diagnosis, liver abscess. Is it amoebic? Is it pyogenic? This is a single large abscess in the right lobe of liver. Single large abscess in the right lobe of liver in patients with cecal involvement is usually amoebic liver abscess. Pyogenic abscesses are multiple both lobes of liver associated with bacteremia. So this is most likely amoebic liver abscess. Okay? Okay, next question. We change the body part now. We are changing the body parts, but the process is inflammation. Don't forget, the process is inflammation. Now look at this kidney. Everybody look at this kidney and look at this kidney. Okay? This patient, listen to me beta, listen to me. Okay? No need to write because I've already compiled everything. Just I want you to listen to me. Okay? Suppose somebody has a UTI. Urinary tract infection is usually seen in the bladder, that is cystitis. If your UTI from the bladder goes into the kidney, infection in the kidney, you will have burning micturition, fever, tenderness of the renal angle. You are suspecting acute pyelonephritis. So my question is this kidney swollen? Yes, acute pyelonephritis. Second thing, remember, very, very important. If you have acute pyelonephritis, the capillaries get blocked by the bacteria. The capillaries in the renal interstitium get blocked by the bacteria and they cause multiple areas of infarction and coagulative necrosis. These infarction will look like wedge-shaped dark areas. Do you agree that this kidney not only has a swollen appearance, it has a striated appearance due to multiple wedge-shaped coagulative necrosis happening in the kidney? Okay. So, what is your diagnosis? What is your diagnosis? Okay, I will repeat. This patient had, okay, try and understand with me. This patient had a UTI from the bladder, it went into the kidney. Patient developed fever, burning micturition and tenderness of the renal angle. On CT, the kidney is swollen along with the multiple blood vessels getting blocked by the infection. You have developed multiple wedge-shaped infarcts. This appearance is called as striated nephrogram. Striated nephrogram on a CT scan is seen in acute pyelonephritis. It is seen in acute pyelonephritis. This is not putty kidney. Many people are getting wrong. No, beta. The acute pyelonephritis, a urinary tract infection of the kidney, acute pyelonephritis. You need to treat it with IV antibiotics. Otherwise, if you delay it, the kidney will become scarred and you don't want to lose a kidney. You have to treat the patient with IV antibiotics. Are you clear? Okay, let's go further. Now, what else can happen? Now, I want all of you to focus on another image. This time, the body part will be bowel, but I will talk about inflammation. Okay. I want all of you to look at this bowel loop. The bowel loop marked by the arrow. Can you see this bowel loop? Okay. And I want you to look at the wall of the bowel loop. Iski wall dekho beta. Entire of the wall is swollen. So, I remind you a term from your pathology class called as transmural inflammation. That means this bowel is inflamed. I am dealing with an inflammatory bowel disease which is involving the small bowel and causing transmural inflammation. Okay. Second thing is, in the mesentery, I can see a lot of streaks. I can see a lot of lines. Why? These are all increased amount of blood vessels. They're looking like a hair comb. Increased amount of blood vessels. Can you think and tell me, beta? Can you think and tell me? That means there is inflammation of the mesenteric border of the bowel. Mesenteric inflammation, transmural inflammation. Already I am able to think that it is an inflammatory bowel disease called as Crohn's disease. Inflammatory bowel disease called as Crohn's disease. Are you okay with it? Okay. Name the sign. The sign that you just saw was Coombs sign. Coombs sign on CT. Okay. Increased vascularity in mesentery looking like a Coombs sign. Okay. Which part of the bowel is involved by Crohn's disease? Crohn's disease can affect any part of the bowel. Any part of the bowel. The involvement can be skip, not necessarily contiguous. Involvement is transmural, and if there is fibrosis, it will lead to narrowing, that is called as string sign of Cantor. That is called as string sign of Cantor. Mesenteric involvement is typical of Crohn's. You can have perianal fistulas. You can have perianal fistulas. And the earliest radiological finding is aphthoid ulceration. The earliest radiological finding is aphthoid ulceration. Okay. Aphthoid ulceration is the earliest radiological finding. These are the features of Crohn's disease. Okay. Again, the body part I am changing. But my guiding principle for the initial part of my class is acute inflammation. What do you see in this patient's gallbladder? You can see a bright echogenic structure with acoustic shadow. Something white with a shadow behind it. What do you think? That is a gallstone. If you have a gallstone, you are predisposed to develop can you see this gallbladder is distended with edematous, swollen, thickened wall. Okay. Now, what are you thinking? You're thinking of cholecystitis. Gallbladder is called as cholecystitis, and itis is inflammation. Cholecystitis. Okay. Now, my question to all of you is, if it is chronic cholecystitis, the gallbladder will be fibrosed and contracted. If it is acute, it is distended with edematous wall. What is your diagnosis? What is your diagnosis? Acute cholecystitis. What is your diagnosis? Acute cholecystitis. Okay. Second question, beta. Second question. Please tell me. Investigation of choice. Investigation of choice for acute cholecystitis is ultrasound. Okay. Investigation of choice for acute cholecystitis is ultrasound. There is a test called as HIDA scan. There is a test called as HIDA scan. HIDA is taken up by the liver, then excreted into the bile. When it is excreted into the bile, it also goes into the reservoir of bile, which is the gallbladder, and it is stored in the gallbladder. In acute cholecystitis due to edema, the gallbladder wall is edematous, the cystic duct is blocked. So what will you see on the HIDA scan? What will you find on the HIDA scan in this patient? A previous inicet question. On HIDA scan, you will find non-visualization of gallbladder. Non-visualized gallbladder on HIDA scan is seen in cholecystitis. Okay. What is the investigation of choice for gallstone? Ultrasound. What is the ultrasound appearance of gallstone? What is the ultrasound appearance of gallstone? On ultrasound, the gallstone appears echogenic with acoustic shadowing. Gallstone on ultrasound appears echogenic with acoustic shadowing. Okay. Very good. Let's see. So investigation of choice for gallstone, ultrasound. What about urinary stone? Gallstone ultrasound मैंने बोला. What about urinary stone बेटा बताओ. Investigation of choice for urinary stone is NCCT. Investigation of choice for urinary stone is NCCT. What about investigation of choice for salivary gland stone? Previous NEET PG question beta. Investigation of choice for salivary gland stone is NCCT. Investigation of choice for salivary gland stone is NCCT. What about CBD stone? If it is a common bile duct stone, then also NCCT, then MRCP. If it is a bladder stone, ultrasound. Okay, can you mark it? Urinary stone, NCCT, salivary stone, NCCT, gallstone, ultrasound, CBD stone, MRCP, bladder stone, ultrasound. Okay, now, why they are asking these questions in NEET PG every time? Because the examiners love stones. Why do examiners love stone? Because stones are tangible. Everybody loves stones. Listen to me everybody, very important at your age. If you give her a stone, she will always remember you. Very, very important. So stones are very important. That is why surgeons, after surgery, they come back and tell the patient, this is the stone that I got from your body. And the patient is always happy. Stones are tangible expression of love. Everybody likes them. So don't forget stones. Very important question in your NEET PG. Okay, next question. Change the body part to bone. Change the body part to bone now. Okay, beta. X-ray off. X-ray of hands. We can see X-ray of hands. Yes, one side, both sides. We can see X-ray of the hand, both sides. Okay, both sides. That means if there is inflammation on both sides, it must be a systemic disorder, systemic inflammatory disorder. Infections and cancer are usually asymmetric. Okay. Now imagine, suppose you have inflammation on the metacarpophalangeal joints. Suppose you have inflammation in the metacarpophalangeal joints, both sides. Inflammation will lead to hyperemia, increased blood flow. In the synovium, because of inflammation, you will have hyperemia. Okay. This hyperemia, if, listen to me everybody, listen to this rule. If there is increased blood flow around a bone, it causes osteoporosis. अगर किसी bone के आसपास blood flow ज़्यादा होगा, तो osteoporosis हो जाएगा. Okay. So now see, the systemic inflammatory disease that I'm talking about, which involves the MCP, PIP, is rheumatoid arthritis. So what are we dealing with? Symmetric involvement of MCP. So remember, diagnosis, rheumatoid arthritis, rheumatoid arthritis. What is the earliest X-ray feature of rheumatoid arthritis? Earliest X-ray feature of rheumatoid arthritis is periarticular osteoporosis. Periarticular osteoporosis. What else will you see? After periarticular osteoporosis, you will develop erosions. Then the joint cartilage will be lost, leading to loss of joint space. Then the joint will have dislocations, deformity. Did you read in orthopedics the deformities like swan neck, boutonniere? So deformities happen in the end. So earliest radiological finding of rheumatoid arthritis is periarticular osteoporosis. Okay. Can you have spine involvement in RA? Can you have spine involvement in RA? Yes. Which vertebra? If you see spine involvement in rheumatoid arthritis, it involves the first and second cervical vertebra. Atlantoaxial joint. Atlantoaxial joint. C1, C2. Okay. Always remember a possible question, always in the exam. Now, let us go a little bit more further. Let us change the symmetric involvement into a child's X-ray. This is the X-ray of a child knee joint. You might ask me Sir, how do you know it is a child? आप बताओ. Sir, child कैसे है? Because the growth plates are open. The growth plates are open. This is a child. Now, in a child, if you have inflammation in the joint, what will happen? Inflammation will lead to increased blood flow. If you have increased blood flow, the epiphysis which is growing will enlarge. अगर बढ़ते epiphysis को ज्यादा blood flow मिलेगा, वो enlarge हो जाएगा. So epiphysis becomes, can you see this large and bulbous epiphysis? This is telling you that this epiphysis is receiving more blood supply. Why? Because of inflammation. Can you think of a inflammatory joint condition in juvenile patients commonly seen in the knee joint? That is called as juvenile rheumatoid arthritis. Juvenile rheumatoid arthritis. Okay? And this condition, okay, this condition on X-ray shows, anyone? On X-ray shows epiphyseal enlargement. Juvenile rheumatoid arthritis, the X-ray feature is epiphyseal enlargement. Okay? Are you clear? In the exam, direct one-liner, epiphyseal enlargement is seen in, please mark, juvenile rheumatoid arthritis. Okay? Let's go further. Now tell me, is this an inflammatory X-ray? Is this patient, is he having an inflammatory joint disease, an infection in the joint, a rheumatoid arthritis in the joint? Is it so? No. Why not? Because in this X-ray, there is joint space loss, but it is not involving the entire of the joint. It is only involving the area which was weight bearing. That means it is involving wear and tear of the cartilage. It is not inflammatory destruction of the cartilage. It is wear and tear of the cartilage causing non-uniform loss of joint space. Non-uniform joint loss space is seen in wear and tear osteoarthritis. Osteoarthritis will happen if you have old age, repeated trauma. So what we see here is wear and tear. Plus, notice the joint margin is having sclerosis. There is no osteoporosis. So, osteoarthritis might show bony spurs, subchondral sclerosis, loose bodies, and your diagnosis will be osteoarthritis. Okay, many people without forming the basics are trying to run, and when you do it without the basics, you know a lot, but in the exam the ranks will not come. To win in life, you need to have a strong basic concept. Even if you don't know hi-fi things, it hardly matters even as a consultant. Okay, so this is not an infection. This is a osteoarthritis of the knee joint. Let us have, okay, give me just 1 second. Let us look at, by the time, please look at another X-ray. Now, please look at another X-ray. Now, please see there is deformity of the knee joint. There is deformity of the knee joint. Is this deformity due to rheumatoid arthritis? Okay, anyone? Is this deformity due to rheumatoid arthritis? Tell me. No, why not? Because there is no osteoporosis. If it was an inflammatory condition, there should be osteoporosis. Here you can see increased density. That means it is wear and tear. But for this to be wear and tear, it looks like a lot of wear and tear. The joint is dislocated, disorganized with a lot of debris. All this tells me that this patient has repeated trauma causing exaggerated wear and tear of the joint. But whenever you have pain, whenever you have trauma, you have pain, you protect yourself. You protect yourself. But this patient must not be protecting himself. Why? Because he does not have sensation. That is called as neuropathic joint or Charcot arthropathy. So do you understand now? What is Charcot's arthropathy? Charcot's arthropathy is neuropathic joint, seen in diabetic patients. If you don't have sensation, the joint will have exaggerated wear and tear due to repeated trauma. It will have increased density, debris, dislocation, disorganization. Okay? Okay, next question. What other inflammatory joint diseases are you aware of? Now, there is another set of inflammatory joint diseases which are seronegative, but HLA-B27 positive. These conditions, they cause, can you see irregularity in the sacroiliac joint? Bilateral. This condition causes bilateral sacroiliitis. This patient also has a red eye because of uveitis, and outer disc fibers are fused leading to a bamboo spine. Can you tell me the condition now? This kind of condition, which is HLA-B27 positive with sacroiliitis, bamboo spine, think of ankylosing spondylitis. In one of the NEET PG exams, they asked a question. What is the earliest X-ray feature of ankylosing spondylitis? What is the earliest X-ray feature of ankylosing spondylitis? Anyone? Earliest X-ray feature of ankylosing spondylitis is blurring off subchondral cortex on the iliac side of SI joint. Earliest X-ray feature of ankylosing spondylitis is blurring of subchondral cortex on iliac side of SI joint. Now remember, before you see sacroiliitis on X-ray, it will be visible on MRI. So always remember, investigation of choice to see sacroiliitis is always MRI. MRI can diagnose sacroiliitis, symmetrical sacroiliitis, much earlier than the X-ray. So see, this was how X-ray was showing sacroiliitis. The joint has irregularity, pseudo widening. This is sacroiliitis. But X-ray will show it late. You need to do a MRI to see early. Can you name some signs of angsponds? Named signs are bamboo spine, dagger sign. Any other sign you can tell me? The vertebral corners show sclerosis in this patient, which is called as shiny corner sign. The named sign of ankylosing spondylitis are bamboo spine, dagger sign, and shiny corner sign. A very, very potential question. Many times in the exam, they simply say bamboo spine X-ray, you need to tell us ankylosing spondylitis. Now, another patient I am showing you, there is a erosion at the metatarsal here. At the great toe, there is a erosion. Okay. Is this because of rheumatoid arthritis? No. Why not? This erosion is not involving the articular margin. It is away from the articular margin with surrounding soft tissue. This soft tissue must be having some crystals. These crystals are causing pressure erosion on the metatarsal. What do you think? We are thinking of a condition called as gout. What are these erosions called as? They are called as rat bite erosion. Any other name? They can also, the sparing of the articular margin is called as Martel sign. The sparing of the articular margin is called as Martel sign. These erosion can also be called as punched out erosion at the first metatarsophalangeal joint. This is the same line that has been asked in a previous NEET PG exam. Punched out, rat bite, martel sign, always think of gout. Always think of gout. Now my question to you is to take you to the next level. When you will go for central exams, they will ask you, can you tell me any modern radiological test, a new investigation that can be used in gout? Which new investigation can be used in gout? The latest investigation that we use in gout now is called as dual energy CT, which is also called as spectral CT. Dual energy CT is now being the preferred radiological thing for gout. Okay. Now I can see most of you are able to understand the differences between different kind of joint diseases. Let us try to make a point that you read in orthopedics. I will try to make a point. I want you to see this leg. This is tibia. This is fibula. Okay. Tibia, fibula. Now I want all of you to tell me, is the disease on one side or both the sides? Okay. Is the disease on one side or both the sides? The disease is in only one side. That means it must be probably an infection going on. Okay. Or a tumor, but it cannot be a systemic disease. Systemic disease will be symmetrical. Second question, why is the bone marrow fat and subcutaneous fat appearing dark? If you remember from the basics of radiology, fat is always white on MRI. So why is the fat appearing dark? We have suppressed the fat signal using a MRI technique called as stir. We have suppressed the fat signal using a MRI technique called as stir. If you have suppressed the fat signal, then why is the bone marrow appearing white? That is edema. This patient has bone marrow edema. What do you think? We think there is an infection of the bone that is called as acute osteomyelitis. Okay. So always remember, bone marrow edema in a child with fever and pain, think of osteomyelitis. Investigation of choice, MRI. How early can you see bone marrow edema in osteomyelitis on MRI? We can see it within 24 hours. You understand? Fat has been suppressed. That is why the normal bone marrow fat is dark. But then why it is white here? Because it is edematous. Stir is a MRI technique which suppresses the fat and helps us to see bone marrow edema. Investigation of choice for acute osteomyelitis, MRI. It can show bone marrow edema within 24 hours. But I hope you appreciate, all I have talked about today so far is itis, inflammation. And we were missing out on the most important link which is connecting us, that most of the diseases processes are only 3 or 4. Either you have an inflammation, acute, chronic, tumor, metastasis, systemic disorder. We need to have that thinking power. Now before I go on, I thought I should remind you of this cricket match. Okay, I should remind you of this cricket match. This is Yuvraj Singh and this is a British bowler that nobody remembers. So Andrew Flintoff in this match between India and England made Yuvraj Singh angry. But Yuvraj Singh, he converted his anger into his superpower and hit this bowler, this sheep in front of him for 6 sixes in an over. Do you remember it or not? Yes, I'm sure many of you remember. Now please go back and think about yourself. I know all of you young people are angry. Youth is always angry. You are angry with family, relatives, society, world, country, politics, everything. But I want you to take out your anger into your work, make it your superpower. Be like Yuvraj Singh. Hit all the questions on NEET PG out of the ground. Okay, next question. Next, now let's change the process. Now imagine a chronic inflammatory process with fibrosis and healing. Now let's imagine a chronic inflammatory process, fibrosis and healing. Okay. Imagine an organ having chronic inflammation. Because of fibrosis, the organ will be contracted, small in size, shrunken, scarred with some calcification. May have calcification. Okay, now please see an answer beta. Everyone, I want you to look at this pancreas. I want you to look at this pancreas beta. Can you see the pancreas? Yes. Tell me. Swollen, shrunken, acute, chronic. Tell me. Now, if you see a pancreas which is shrunken, calcified, it is chronic pancreatitis. Chronic pancreatitis. Okay? Are you clear? Chronic pancreatitis. What is the investigation of choice for chronic pancreatitis? Anyone? Investigation of choice for chronic pancreatitis is MRCP with secretin. If that is not in the choice, I will mark CCT. Investigation of choice, MRCP with secretin. If they ask me best investigation, I will mark endoscopic ultrasound. Endoscopic ultrasound. Now, paradox. Listen to me, everybody. If a patient is having chronic pancreatitis, the organ should be shrunken. If the organ, instead of shrinking, becomes like a sausage, then what will you think? Anyone? If the pancreas in chronic pancreatitis is not shrunken but like a sausage, what will you think? You will think that something unusual is going on. Maybe this patient is having IgG4 related autoimmune pancreatitis. Okay? Sausage shaped pancreas is seen in autoimmune pancreatitis associated with IgG4. IgG4. Possible question for your May inicet exam. Sausage shaped pancreas seen in autoimmune pancreatitis. Are you done with this or not? Yes, let's go next question now. Next question. This investigation is MRCP. On this MRCP, I want you to look at the pancreatic duct. On this MRCP, I want you to look at the pancreatic duct. There is a chronic inflammatory process going on leading to multiple strictures. Because of the multiple strictures, pancreatic duct has stricture, dilatation, stricture, dilatation, stricture, dilatation, stricture, dilatation. This kind of appearance on MRCP is called as chain of legs appearance. Chain of legs appearance on MRCP is a feature of chronic pancreatitis. Chronic pancreatitis. Are you able to do it? Stricture, dilatation, stricture, dilatation. Chronic pancreatitis. Okay. Again, a possible visual for your NEET PG exam. They like asking pancreatitis as well. Okay. Next question. Look at the normal barium enema. This is how, look at it now. This is how your large bowel should be. It has incomplete folds called as haustray. Your large bowel has incomplete folds called as haustray. This test is barium enema. This test is barium enema. And always remember, out of all the barium tests, barium enema has the maximum radiation exposure. Out of all the barium tests, barium enema has the maximum radiation exposure. Okay. Now I want you to look at an image and tell me another barium enema for you. What is wrong with this barium enema? The entire of the colon has become small, fibrosed and ahaustral in a contiguous fashion. What do you think? Chronic inflammatory bowel disease involving the colon with ahaustral lead pipe like colon. Always think of ulcerative colitis. But now you see, we are making a pattern. First our pattern was acute inflammatory process, then we went on to chronic and fibrosis. Now we are able to see, if you have a chronic inflammatory colitis called as ulcerative colitis, in the end the colon will become like a lead pipe. Okay, Quick questions. Starts at. Ulcerative colitis starts at rectum. Problem is mucosal. Remember in Crohn's I told you the problem was transmural. Here the problem is mucosal. You can have pseudopolyposis, contiguous involvement. Earliest finding is mucosal granularity. While in Crohn's the earliest finding was aphthoid ulceration. In Crohn's the earliest finding was aphthoid ulceration. In ulcerative colitis the earliest finding is mucosal granularity. Mucosal granularity. Are you able to do it? Okay, let me do it. Okay, next. Okay, 2 questions. Kidney. Okay, everyone see with me. Better see this. See this kidney and compare with this one. What do you see? The right kidney in this patient is contracted. Fibrosis, scarring. That means this patient must have a UTI causing chronic pyelonephritis leading to a unilateral scarred kidney. Okay, are you able to identify? You can see a unilateral scarred kidney. Now my question is, okay, everybody try and answer. What is the investigation of choice to look for renal scarring? Investigation of choice to look for renal scarring is, anyone? Technetium DMSA scan. Technetium DMSA scan. Okay. And what is the investigation of choice to look for vesico-ureteric reflux? Investigation of choice to look for vesico-ureteric reflux is, so reflux maximum happens when the bladder pressure is maximum. It happens during micturition. So the investigation of choice will be MCU. Investigation of choice for vesico-ureteric reflux is MCU. Okay. Now we see the next image. Okay. In the next image, this kidney is contracted. But is it only contracted? It is not only contracted. There is chronic inflammation. Definitely it is contracted. But it is also dead now. Because it is dead, it has developed dystrophic calcification. It is calcified. Okay. Now what do you think? Now when I see a unilateral contracted calcified kidney, now normally I want you to listen to me. If you listen to me, you will form the concept. Okay. Just one time listening, because you have always been speaking. I want you to listen. Okay. Now when I go infection from the bladder, it goes to the kidney. So usually by the time it reaches the kidney, you start antibiotics and you don't have time for kidney to calcify. But what if an infection starts in the kidney, not in the bladder? That is hematogenous, that is tuberculosis. TB in the kidney is a hematogenous infection. And it is starting in the kidney, and the kidney becomes chronic, involved, scarred, calcified, called as the putty kidney, cement kidney. And if they say investigation of choice for renal tuberculosis, if they say investigation of choice for renal tuberculosis, please mark CT urography. Please mark CT urography. Bladder in this patient will become like a thimble bladder. Thimble bladder. Ureters will be beaded. They might have a sawtooth appearance. Beaded ureters, sawtooth appearance. Golf hole ureteric orifice on cystoscopy. But remember, now we are looking at chronic infection. One is ascending into the kidney, second is hematogenous, and we see that this particular kidney and in the end gets calcified. TB kidney gets calcified, non-functional. Okay? Okay. Next question. What if you have a chronic inflammatory process going on in the interstitium, in the connective tissue of the lung? If you have a chronic inflammatory process going on in the connective tissue of the lung, you will have interstitial lung disease. These patients will come to you with breathlessness, long history of breathlessness and dry cough. You need to do a high resolution CT to see the detail that you see in front of you. This is a HRCT. All I want you to do is look at the lung base. Can you see these multiple cystic spaces? I want you to pay your attention here. Can you see these multiple cystic spaces? These are called as honeycombing. This patient has basal subpleural, basal subpleural honeycombing. That means honeycombing means irreversible fibrosis in the interstitium, a chronic process happening. Fibrosis will always pull. This fibrosis will pull the bronchus, and when you pull a bronchus, it becomes dilated. And the term that we use here is, anyone? Traction bronchiectasis. My question to you is, in a patient with interstitial lung disease, if you see honeycombing, traction bronchiectasis, it tells you irreversible fibrosis has happened in the lung. Poor prognosis. You might have to go for a lung transplant as a treatment. What is the diagnosis? UIP. This condition is called as UIP, usual interstitial pneumonia. Prognosis, poor. Prognosis, poor. This is called as usual interstitial pneumonia. It is basal subpleural involvement. Basal subpleural involvement. But what if the same patient, same history, comes with a different image? Then some of you are getting confused. I will show you that also, beta. Just have patience. So I am seeing some of you getting confused between how to see bronchiectasis, honeycombing. Let me explain. Just have patience. Honeycombing looks like these cystic spaces stacked over one another. Bronchiectasis looks like this. You will see tubular, tram track like shadows, or you will see a bunch of grape like lucences. This is bronchiectasis. So when you see these signs, remember, tram track, signet ring, bunch of grapes. You can see dilatation of the bronchi. After infection, the scarring has led to irreversible dilatation of the bronchi, called as bronchiectasis. So what are the named signs of bronchiectasis? Tram track, signet ring, bunch of grapes. Now, can anybody tell me if bronchiectasis in the upper lobe is associated with pancreatic insufficiency, what will you suspect? If bronchiectasis in the upper lobe is associated with pancreatic insufficiency, you will suspect cystic fibrosis. And I'm sure you will set the chat box on fire. I'm sure you know it by now. बहुत सारे लोग e-learning की बात करते हैं, but the only lit space is the DAMS eMedicos app, where education is happening live every single day. It is not a pre-recorded content being doled out to you. Now, if you tell me bronchiectasis with situs inversus, infertility, sinusitis, Carter-Jenner syndrome. Bronchiectasis with situs inversus, infertility, and sinusitis, it is Carter-Jenner syndrome. Are you clear now? Possible questions for your upcoming NEET PG exam. Now, suppose in a patient with interstitial lung disease, you see basal ground glass opacities and subpleural sparing. Some of you are mentioning this in the chat box. Now tell me, basal ground glass opacity, subpleural sparing, HRCT is shown to you. You should always think of, tell me, NSIP. You should think of NSIP, non-specific interstitial pneumonia. This will have better prognosis. UIP, poor prognosis. This is what is called as non-specific interstitial pneumonia. Ab samajh aa gaya beta? Okay, let's go further. Now we met one cricketer called as Yuvraj Singh. Now I will help you I introduce you to Sachin Tendulkar. हम सब सचिन तेंदुलकर बनना चाहते हैं, आप भी बनना चाहते हो, जीतना चाहते हो. We want to become the champion that he is. But do you remember when he started cricket? Waqar Yunus was bowling to a kid, he was a kid, most younger than you, and a ball hit his nose. Uske naak toot gayi wahan pe, and he was bleeding. Azharuddin, before the match fixing scandal happened, he came, he said, "Tu khelega ya wapis aayega?" He said, "Main khelega." And that is what made him the champion that he is today. He was bola, "Main khelega." So I told you so far that you need to convert your anger into your power, your pain into your power. Sachin Tendulkar that day had pain, but he channelized it into his superpower. Some of you may have pain, but if you can put it into work, you will win. Today I am telling you a story. I am today telling you a story which is very important and is very inspiring for me as well. Recently, this boy was chatting to me and Dr. Deepti. This boy had cerebral palsy. And he said that, "Sir, I'm preparing for central exams. I'm preparing for inicet." I said, "Why do you want to prepare for central institutes?" He told me that the central institutes have better infrastructure. They are more friendly as a campus for his kind of people. Otherwise, if he goes to a state medical college, these colleges are insensitive. Point taken. And he said, "I'm working for inicet." He kept working. And this time in November, he has a rank 190 after cerebral palsy. And he studied, he's got a rank 190. Can you imagine? He could channelize his pain into his superpower. I told him, "I want to take an interview of yours." He said, "Sir, he's undergoing some surgery. After that, he will give us an interview definitely." But he was studying live on the Ultimate Live course, just like you are on the eMedicos app. That is the power of technology. But the power is in channelizing your pain and converting into your superpower. Sachin Tendulkar did it. Can you do it? Can you do it? Okay. Let's go to the third pattern. Acute inflammation, chronic inflammation. Third pattern is, am I looking at a cyst or a solid lump? Remember in surgery they told you, you need to understand the lump. Any swelling or lump can be solid or cystic. A cyst will be thin-walled, will have fluid inside, and it will be benign. Solid will be tumor. Cyst will be benign. Solid will be tumor. So we need to differentiate. Investigation of choice to differentiate solid versus cystic is ultrasound. Investigation of choice to differentiate solid versus cystic is ultrasound. Now, let's look at some cysts. Okay? Different body part, answer will be cyst. Okay? Anterior cranial fossa, middle cranial fossa, posterior cranial fossa. Where is the disease? You can see a CSF-filled cyst in the middle cranial fossa. Is it an infection? No. Why not? Infection should have a ring-like enhancement. It looks like a cyst. Congenital cyst in the middle cranial fossa is called as arachnoid cyst. Congenital cyst in the middle cranial fossa incidentally discovered is called as arachnoid cyst. Most common location, middle cranial fossa. Most common location, middle cranial fossa. And the key word in the question will be isodense, same as CSF. It should look similar to CSF. Okay. Now I will change the question. Okay. Okay, I will change the question, beta. Everybody try to see now. Okay. Oh, that green color in the logo, sometimes it gets cut by the chroma. Some people are saying there's a hole in my chest. There's no hole. Sometimes because the chroma background in the studio, sometimes the green color in the logo works. But you guys have lit sense of humor. Now, everyone, look at this liver. There is a cyst in the liver. There is a cyst in this patient's liver. Now, this cyst is not a pure cyst. It has some stigmata telling that it is a living organism. It's a parasite. What is it? Inside this cyst, you can see multiple daughter cysts. It means it is a parasitic cyst which is dividing, giving rise to a cartwheel-like appearance. And in the second cyst, you can see a membrane inside. Again telling you it is a parasitic cyst which is called as hydatid. Hydatid. Are you clear? Hydatid. Okay. So what are the name signs of hydatid? Hydatid cyst can have sand inside. That means the scoliosis can look like sand on ultrasound. The daughter cyst can look like a cartwheel. It can have a crumpled membrane inside. It can look like a serpent. But if it is in the lungs, remember, if the hydatid is in the lung, on chest X-ray it shows water lily sign. On chest X-ray, hydatid shows water lily sign. Okay, always remember, beta, always remember. Everyone, tell me, chest X-ray, remember, water lily sign, hydatid. Examiners, they love flowers. Why they love flowers? Try to understand. I taught you so far. If you give her a stone, she knows that you're serious. But if you don't afford a stone, don't panic. You can always give her a flower. Okay. Examiners, they love stones and flowers in the exam. If you don't afford a stone, don't panic. Give her a flower. Okay. Let's move forward now. Next question. Next question now. Now again, the parasite can reach the brain as well. So you can have a parasitic cyst in the brain. I want you to look at these multiple cystic lesions in the brain. This is a previous NEET PG image. Previous NEET PG image. Now tell me. Now tell me, is this a pure cyst or a parasitic cyst? It is a parasitic cyst. Why? You can see a scolex inside. You can see a scolex inside. This is a cyst with a scolex. Neurocysticercosis. Neurocysticercosis. Okay? But don't forget, when the parasite dies, it becomes calcified. When NCC dies, it becomes calcified. Look at another NEET PG image. You can see multiple calcified nodules throughout the brain parenchyma. This is also NCC. So neurocysticercosis, always remember, neurocysticercosis is always a possible question because it's a common infection in India. Common things are commonly asked. Common things are commonly asked. NCC has 3 stages. Viable stage is called as vesicular. Viable stage is called as vesicular. Dead stage is calcified. Degenerating is colloidal. Only one question. Which stage has maximum symptoms and maximum edema? Which stage has maximum symptoms, maximum edema? Okay. Maximum symptoms and maximum edema is colloidal stage. Colloidal stage. Colloidal में सबसे ज़्यादा edema, सबसे ज़्यादा symptoms. Okay. Somebody asking, sir, आपने मैडम को क्या दिया? शुरू में फूल दिया. Very important. Flowers are very important. Don't miss out on it. Okay. Next go. So cyst can be in any part of the body. Cyst can be in any part of the body. You can simply have a cyst in the kidney. Can you see a simple cyst? Many times when I'm doing an ultrasound, in old people, you may have a simple cyst. Ignore it. It has no significance. It is benign. Simple cyst. Benign. The only reason the significance will happen if the cyst has some solid tissue or some thick septae. So we need to have a nomenclature. For renal cysts, we follow a nomenclature called as Bosnack classification. A cyst which is clear is benign, ignore. But if it has septae or solid component, and I'm sure you read the same thing in ovary also yesterday, if you remember, that is the symmetry of the body. You have to know the basic concepts. The body parts hardly matter. We need to know cyst is benign. If it has solid tissue, internal vascularity, septae, it could be cancer. That is the basis of Bosnack classification in renal cyst. Always remember, Bosnack category 1 and 2, ignore. 3 and 4, need surgical management. Possible question. Bosnack classification is used for renal cysts. Cyst is benign. Okay. Cyst is benign. Okay. Some bachcha saying, sir, wo NCC ka dead stage was calcified beta. Calcified. Okay. Next go. What if the cysts are multiple? अब तो गड़बड़ हो गया. ये तो कुछ दोनों तरफ है. If I see multiple cysts, enlarged kidney, both sides, maybe it could be something genetic happening. Multiple can be called as poly. Then we use a term ADPCKD, autosomal dominant polycystic kidney disease. Possible, my predictor for your upcoming NEET PG exam. Enlarged kidney, polycystic kidney disease. Both kidneys are enlarged with multiple cysts, ADPCKD. ADPCKD. Okay. Now, questions. What is the investigation of choice for ADPCKD? Investigation of choice, CECT. Investigation of choice for ADPCKD is CECT. How will you do screening of his family members? How will you do screening of his family members? All his family members, because it's a genetic disease, for them also you need to do an ultrasound. Because they can also have a disease because it's a genetic disease. How will you do screening of his brain? Why do I want to see his brain? Polycystic kidney disease, the patient can have a cerebral aneurysm, berry aneurysm. I need to do an angiogram. Should I do CT angiogram or MR angiogram? Go back to PSM. PSM people told you screening should be done with harmless investigation. CT scan has radiation exposure. I want to do screening. I use MR angiogram. MR angiogram. Okay. Screening of the brain is done with MR angiogram to look for berry aneurysms. Okay. And by the speed at which you are answering in the chat box, I already can sense that the topper of next year's NEET PG is already there in the chat box. Yes, I'm talking about you. And I'm super impressed by the energy that you guys bring to the table. Super excited, beta. Very good. And a cyst can be in the ovary. Solid versus cystic, we always do ultrasound. Cysts are anechoic. Anechoic, they appear dark. And behind them you see a bright area that is called as acoustic enhancement. Cyst, okay. Cysts are anechoic and they show acoustic enhancement. This is benign cyst. Just wait and watch, conservative management, nothing to be done. But if a cyst looks like this, thick septae, internal vascularity, solid tissue, in ovary, it hardly matters, it is ovary, kidney. Any cyst with thick septa, internal vascularity could be a cancer. You need to evaluate for cancer. Okay? Clear? Okay. But some of these cysts can have a atypical component. Let us try to understand this very important question. Very important for everybody's life also. Please remember. Can you see this cyst has some dark area? How dark? As dark as the subcutaneous fat. As dark as the subcutaneous fat. But there is also a tooth-like calcification. A pelvic ovarian cyst with fat and calcium. Anybody has a guess to make? Pelvic ovarian cyst with fat and tooth. Always think of dermoid. Always think of dermoid. Okay. So what is the clue for dermoid in this question? Fat and tooth. Ectodermal derivatives. But there are some interesting names in dermoid which are asked in NEET PG as one-liner. Remember them. Rokitansky protuberance. Rokitansky protuberance leads to tip of iceberg sign. Remember, tip of iceberg sign on ultrasound. In dermoid, you will have hair. Dermoid, you will have hair. Okay. These hair, when you do an ultrasound, some of them will look like a dash, some of them will look like a dot. Because some of them, it's a bunch of hair. Some will be cut in dots, some will be like a line. Dot, dash sign. And the fat globules look like a sack of marbles. So what are the named signs of dermoid cyst? Rokitansky protuberance, tip of iceberg sign, dot dash sign, sack of marble sign. Okay, tough question now. Can you tell me about a cyst which is found in the brain at CP angle? Cyst, not tumor, cyst, which has keratin-rich material. Think of it. Can you tell me a cyst in the brain which is found at the CP angle and is rich in keratinous material? That cyst is called as epidermoid cyst. That cyst is called as epidermoid cyst. Because this epidermoid cyst has keratin-rich fluid, this fluid will be viscous, thick, and it will appear bright on diffusion-weighted MRI. Just like brain abscess, abscess also has thick fluid, it is bright on diffusion. Epidermoid cyst is also bright on diffusion. Most common location is CP angle. So there are two cystic lesions in brain. We need to remember both of them are benign. Arachnoid cyst, epidermoid cyst. Can be differentiated by diffusion weighted MRI. Can be differentiated by diffusion weighted MRI. Most common location, CP angle. The fluid is thick, keratin rich, and that is why it is bright on diffusion. Can you have a cyst in the bone? Can you have a cyst in the bone? Yes, usually in children. In children, you can have a bone cyst, a simple bone cyst. Now, please see this. This is your, anyone? Tell me. Growth plate. That means it is a immature skeleton. This is a child. There is a cystic lesion in the metaphysis. Where is the tumor? Where is the lesion? Metaphysis. Is it expanding the bone or not? Is it central or eccentric? It is central, non-expansile. If you see a central non-expansile cystic lesion in the metaphysis of a child, it is a simple bone cyst. If it has a pathological fracture, that broken fragment can be seen as a trap door or a fallen leaf sign. A trap door or a fallen leaf sign. What is the diagnosis? The diagnosis is simple bone cyst, also called as unicameral bone cyst. So remember, we saw a kidney cyst. I'm showing you a bone cyst. Only the body parts are changing. The pathology remains same. Benign cyst, nothing to be done. Benign. It has a pathological fracture that is causing the symptom. Okay. Okay. Now, I will try to trick you now. This is again a child. The growth plates are open and you have a lesion in the metaphysis. In child, in metaphysis, usually you have a cyst. But is it a cyst? Is this a cyst? What is the problem? It is in the metaphysis, but what is the problem? It appears expansile. It is expanding. Then I think, is it a tumor? Because a tumor will be dividing, it should expand. But tumor, the giant cell tumor is seen in epiphysis. This is in the metaphysis. It looks like a cyst, but is expansile. That tells me, okay, that tells me probably it is a cyst which has a lot of vascular spaces. These vessels are pulsating. Because of the pulsation, it is expansile. This is not a simple bone cyst. This is a aneurysmal bone cyst. This is a aneurysmal bone cyst. Okay. Okay. Now, let me show you the third part now. Please see. Now, age, adult, mature. Because the growth plate has already fused. You can see in the epiphysis, subarticular, eccentric, expansile, soap bubble lesion. What is your diagnosis? Expansile, soap bubble, eccentric, epiphyseal. What do you think? We know we are dealing with giant cell tumor. We're dealing with giant cell tumor. Out of these three, one question is very often asked in the NEET PG exam. Simple bone cyst, aneurysmal bone cyst, and a GCT. Okay. Now, cyst can be anywhere, and we need to keep thinking, is it a cyst or is it a tumor? Please see, beta. Everybody look at me. Everybody look at me. Cerebellum has a shape which is like this. Can you see? Cerebellar shape is like this. On the top of the cerebellum, you have the tentorium. So, above the tentorium, you have cerebrum. Below, you have cerebellum. Can you see a cystic lesion in the cerebellum? Can you see a cystic lesion in the cerebellum? Yes. But now as a doctor, you need to look at it. Is it only cyst or do you see some solid tissue? Do you see some solid tissue? Tell me. Yes, there is a mural nodule. It is a cancer. It has a solid tissue. Now, if you see a cyst with a mural nodule in the cerebellum, always think of hemangioblastoma. Always think of hemangioblastoma. Okay. Now tell me, hemangioblastoma associated with anyone? Associated with von Hippel-Lindau disease. Von Hippel-Lindau disease. Hemangioblastoma in the cerebellum. Previous NEET PG question seen in VHL. Which ENT tumor? Okay, beta. Which ENT tumor is associated with VHL? Which ENT tumor is associated with VHL? In kidney, you have clear cell RCC, but what do you see in ENT? Kidney, clear cell RCC. What do you see in ENT? ENT tumor associated with VHL is called as, anyone? Endolymphatic sac tumor. Endolymphatic sac tumor. Endolymphatic sac tumor. Possible question. Has never been asked so far. Okay. Now, again, in pancreas, I told you, if you have pancreatitis, after 4 weeks, you have cystic lesion, that is a pseudocyst. But if in a female patient, you see a cyst with no history of pancreatitis, think of cystic neoplasms. I want you to look at the first one. If in a grandmother, if in an old lady, you see multiple cysts in the pancreas with a central stellate calcification, what do you think? Tell me. Pancreas, old lady, no history of pancreatitis, multiple cysts, central calcification. Always think of serous cystadenoma. Always think of serous cystadenoma. है ना बेटा FNH जो आप बोल रहे हो बेटा वो लिवर में होता है ये पैंक्रियास बोला मैंने पैंक्रियास सेंट्रल स्कार इन अ लिवर लीजन फोकल नोडुलर हाइपरप्लेसिया central scar in a kidney tumor oncocytoma central scar in a pancreatic cystic tumor serous cystadenoma commonly seen in old lady. If you see a single cystic lesion in a middle-aged female with no pancreatitis, then think of mucinous cystic neoplasm. Mucinous cystic neoplasm. So remember, cysts are benign, but remember when to think of malignancy. Okay. Okay. Is it better now? Give me a thumbs up if you're back. If you're back, I'll repeat it. Okay. So in pancreas, many times we forget we have in women cystic neoplasms. In an old lady, if you see multiple cysts in the pancreas with central calcification, that is serous cystadenoma. In a middle-aged woman, if you have an oligocystic lesion, mucinous cystic neoplasm. Mucinous cystic neoplasm. Are you clear? Mucinous cystic neoplasm. Okay. Done. Multiple cyst, central scar, serous cystadenoma, old lady. Single cyst, middle-aged woman, mucinous cystic neoplasm. Okay. Now, I also wanted to point out to you that it is up to your belief. The power is not in our bodies. Power is in our mind. Everything happens in the mind first and reality later on. This is the rule of the universe. If you truly believe that you want it, everything will happen. You need to build that belief. You need to channelize yourself. Otherwise, you will keep reacting to the situations. कई बार क्या होता है, I see students who are only, I see people who are only reacting to the situations. ऐसा हुआ तो मैं ये करूंगा, ऐसा हुआ तो मैं ये करूंगा. फिर जिंदगी का प्लान ही नहीं बनाया, and you don't have anything to believe, you will reach middle age very fast without realizing that you've done nothing, and then you will have full of regrets, a midlife crisis. I see it happening all around me. You need to channelize your energy by something that you truly believe. Okay, is it better? Is it better? I've reduced the bit rate. Okay, so I've reduced the transmission quality a little bit. So I hope this works now. Okay. Well, we are doing a very high resolution broadcast for you, so I've reduced the broadcast size. Okay, next go on. Okay. So now I want you to look at the next picture. What do you think? Cancer, cancer, solid cancer. Now so far we have seen if it is an infection, it will be like a ring. If it is a cyst, it will be non-enhancing fluid filled. If it is chronic inflammation, it will be fibrosis, scarred, calcified. If it is a cancer, it will be solid. Okay, it will be solid. Okay. Okay. If it is a cancer, it will be solid. Let us see. I want you all to go one by one on this. Please look at this image. Everyone look at this image. Please see the image, beta. Okay. And I want you to see this here. Is this an infection or a tumor? It is taking up the dye throughout the body of the tumor. It has internal vascularity. It looks like a tumor. This tumor is attached to the dura. This tumor is attached to the dura and it has a dural tail sign. What is the idea? So if you see a tumor attached to the dura with a dural tail sign, we think of meningioma. And meningiomas are associated with NF2 and prior radiation exposure. NF2 and prior radiation exposure. Okay, go back, and now see. Again, this is your pons, cerebellum. You see a tumor. Sir, why this is not infection? It is solid. It has internal vascularity. You see a tumor in the CP angle going into internal auditory canal like a ice cream cone. Like a ice cream cone. It is solid. Solid means entire of the lesion is showing enhancement. It has cells and blood vessels in the internal part of the tumor. It has internal vascularity. It is a tumor. Now this tumor in the CP angle with ice cream cone appearance is called as vestibular schwannoma. Okay. Even vestibular schwannomas are associated with NF2. Tumors which are associated with NF2 are vestibular schwannoma, meningioma, ependymoma. Vestibular schwannoma, meningioma, ependymoma. Okay. Now see the third tumor, beta. Let's see the third tumor, beta. Third tumor is seen in the center of the brain with a snowman or a figure of 8 like appearance. This is arising from the pituitary and reaching up to the optic chiasma, compressing the optic chiasma, causing visual field defect. This is pituitary macroadenoma. Pituitary macroadenoma. These are three common visuals that you see in the tumors in the exam. A meningioma, vestibular schwannoma, pituitary macroadenoma. Meningioma, vestibular schwannoma, pituitary macroadenoma. Okay. Now let's see. I will now give you an image and now you need to connect them. Can you somehow connect the images that are being shown to you? Can you connect these two images? Let's see how many of you can put the chat box on fire. Let's see how many of you are there alive and kicking. Tell me. You can see a dural based tumor, solid tumor, meningioma, ice cream cones on both the CP angles, bilateral vestibular schwannomas. Connect the two. Connect the two. Connect the two, beta, connect. NF2. NF2. Okay. NF2 has three tumors. VSME. Vestibuloschwannoma, meningioma, ependymoma. That was VSME. Vestibuloschwannoma, meningioma, ependymoma. Okay. Okay. Let's look at this again. Hai na? Now look at it with the imagination and don't think of anything else. Just think. Is this a tumor? Yes. But why it has enhancing areas and non-enhancing areas? This tumor is growing so fast. This tumor is growing so fast that many areas it is outgrowing the blood supply. It has areas of necrosis. Areas of necrosis. Okay. With, if you remember from your pathology, necrosis with surrounding by pseudopalisading of cells. This tumor looks like an aggressive high-grade primary neoplasm in an adult, crossing the midline like a butterfly, crossing the midline like a butterfly. What do you think? We know we are dealing with glioblastoma. We are dealing with glioblastoma. Prognosis, poor. Looks like a butterfly. Looks like a butterfly, but it is poor prognosis, high-grade neoplasm. Are you able to form the concept now that now your approach is different? Now you are not doing random things, sir. NCC क्यों नहीं है, sir? भाई ट्यूमर लग रहा है, सॉलिड है, नेक्रोटिक एरिया है, मिड लाइन को इज्जत नहीं दे रहा, हैज टू बी हाई ग्रेड ट्यूमर, क्यों गड़बड़ कर रहा है भाई, है ना? डू यू अंडरस्टैंड दिस ऑल? इट इज क्रॉसिंग द मिड लाइन, इट इज हेट्रोजेनस, हैज नेक्रोटिक एरियाज. Please mark glioblastoma. And we have kept pathology today so that in pathology you will be able to correlate the microscopy today itself. Okay. This is the malignant tumor that we saw in the adult. Can you tell me which malignant tumor of brain is seen in children? Which malignant tumor of the brain is seen in children? It is a midline location posterior fossa tumor called as medulloblastoma. Medulloblastoma. Medulloblastomas are radiosensitive tumors. They are known to cause metastasis in the spinal canal. Can you see the metastasis, the tumor nodules in the spinal canal? These tumor is spreading via CSF, usually seen in children. Usually seen in children. This CSF drop metastasis is called as sugar icing appearance. Sugar icing in German is called as Zuckerguss. Like sugar icing around the spinal cord, you can see multiple nodules of tumor. Sugar icing on Zuckerguss appearance. So in your NEET PG, they have asked a question. Which brain tumor shows CSF drop metastasis? Medulloblastoma. CSF drop metastasis, medulloblastoma. Zucker means sugar, gus means icing, sugar icing appearance. Okay. Now I will remove myself and you just need to look at the 4 images and connect the dot. Can you think of a disease which is involving the brain, heart, lung, kidney? Connect the dots, beta, connect the dots. I told you we will imagine a lot today, okay? The supreme form of intelligence is not memory, it is imagination. Okay, anyone? Okay, I will help you, beta. I will help you. In the kidney, you have multiple lesions which are dark. Dark because they contain fat. These are angiomyolipomas. Angiomyolipomas. In the kidneys, angiomyolipoma. In the lungs, multiple cysts, multiple dark holes. These are called as lymphangiomyomatosis. In the heart, rhabdomyoma. Rhabdomyoma. In the brain, subependymal calcified nodules. Can you put them together now? Connect the dots. Tuberous sclerosis. Tuberous sclerosis. Okay. Are you able to do it now? So we have to think imaginatively. We have to enjoy the art of medicine. We can't keep saying कि सर ये काम कर रहे हैं. हम नौकरी नहीं कर रहे, अपन डॉक्टर बन रहे हैं भाई. यहाँ पे we need to use our imagination, intelligence, personality, kindness, everything. We need to make sure that we bring value to the system. Let's connect another dots. Okay, I'm going out so that you can enjoy some, okay, don't tell anybody, but enjoy some port wine. Now tell me, which condition on the skin has port wine stain? In the eye has glaucoma. In the brain, half of the brain is atrophied, hemiatrophy, tram track calcification. Anyone? Hemiatrophy, tram track calcification, port wine stain, glaucoma. Connect the dots. Connects the dots. The dots are connected at Sturge-Weber syndrome. If you connect the dots, it becomes Sturge-Weber syndrome. Sturge-Weber syndrome. Well done. I can already see the most intelligent students are right now on DAMS eMedicos app. With the speed that you are answering, I am sure the examiners will be shocked by your knowledge and the rocked. Okay, legendary students are here. Okay, legends. Okay, remember, ordinary people do recorded lectures. Legends attend live sessions. Now tell me, 3 images, connect the dots. 3 images, connect the dots. Okay, first image. First image, behind the globe you can see a solid tumor. Behind the globe you have optic nerve. So that means you must be having a optic glioma. Optic glioma. Okay, what is in the bone? It looks as if a joint has formed here, but it's not a joint. Pseudoarthrosis. Pseudoarthrosis. Sphenoid bone is absent, leading to a empty or a bare orbit. Sphenoidal dysplasia. Can you connect the dots now? Optic glioma, tibial pseudoarthrosis, sphenoid dysplasia. Can you connect the dots and let me know that you are there? NF1. The answer becomes NF1, chromosome 17, von Reckling-Husson disease. Von Reckling-Husson disease. Okay. Very good, everybody. Okay, so I am going to go back to this tram track and story. This is gyral calcification. The gyri of the brain have become calcified. This is also called as tram track. Port wine, hemiatrophy, Sturge-Weber. Okay. Okay. Let us integrate a little bit of ophthalmology also. The first image is a CT scan. Why this is a CT scan? Because bones are white. Bones are white. And in this particular patient, the globe is enlarged. It has a tumor inside. And the tumor is as white as the bone. It is calcified. Okay. So think of a tumor and tell me. NCCT in this infant has a calcified intraocular tumor. Calcified intraocular tumor is retinoblastoma. Retinoblastoma. Can be bilateral. Here it is unilateral, can be bilateral. If it involves the pineal, it becomes trilateral. Okay. Now, when you have to decide for the surgery in this patient, you need to know optic nerve involvement. So what is the investigation of choice? We need to see optic nerve involvement. Investigation of choice, MRI. Investigation of choice, MRI. So that you can look for optic nerve involvement. Okay. Another question is, what finding do we see? What is a typical question for ophtha and MRI? I will tell you. Look at the globe. Look at the globe. The water is dark, T1 weighted image. Water is white, T2 weighted image. Usually, diseases should be white on T2, dark on T1. Here I am able to see the opposite. There is a tumor in the globe which is white on T1 and dark on T2. White on T1, dark on T2. What do you think? That tells me this tumor has a magnetic substance inside, that is melanin, that is choroidal melanoma. Choroidal melanoma. Melanomas will have melanin. Melanin will cause it to become white on T1, dark on T2. This is different from usual. Usually you have pathologies are white on T2. But tumors containing melanin like melanoma will be bright on T1. Okay? Okay. You can have cancers in the liver, cancers in the kidney. Now my question is, what cancer, primary cancer do you see in liver? What cancer in the liver in cirrhotic patients? Hepatocellular cancer. Hepatocellular cancer. Okay. Let's go one by one. Okay. Let's go one by one. What is the investigation of choice for hepatocellular cancer? What is the IOC? Investigation of choice is triple phase CT. Investigation of choice, triple phase CT. What will you see in the, there are three phases: hepatic arterial phase, portal venous phase, equilibrium phase. What will you see in the arterial phase, venous phase and equilibrium phase? HCC will show enhancement in the hepatic arterial phase. Enhancement in the hepatic arterial phase. Washout in the portal venous phase. And capsule in the equilibrium phase. Possible question, beta. Again remember, I am going back, okay? Hepatocellular cancer shows enhancement in the arterial phase, washout in the portal venous phase, capsule in the equilibrium phase. Okay? If they change the question and say, what is the screening investigation for HCC? Hepatocellular cancer can happen in patients with cirrhosis. Cirrhosis, can you see nodular outline to the liver? Cirrhosis. Cirrhotic patients should undergo a 6-monthly ultrasound to screen for a suspicious tumor. So what is the screening test? Ultrasound. Screening test, ultrasound. Okay. Now always remember, you can have a kidney tumor as well. Please see, this is a solid tumor arising from the kidney, usually an RCC. If there is a central scar, then oncocytoma, this is a RCC. Okay, this is a RCC. Can you tell me, most of the carcinomas spread via lymphatics? Can you name 2 carcinomas which grow into veins? 2 carcinomas which grow into veins are HCC, RCC. HCC and RCC are known to grow into the veins. Okay. Okay. Now, further, you can have sarcomas in the bone. Can you see the first image? There is a bone which is more dense and the tumor is extending along the Sharpie's fibers in a sunray-like appearance in the soft tissues. There is a small Codman triangle also visible. What do you think? Osteosarcoma. Osteosarcoma. In the second image, you can see a multilamellar periosteal reaction looking like an onion peel. Ewing sarcoma. Ewing sarcoma. Ewing sarcoma is radiosensitive. Osteosarcoma is radioresistant. Okay, sunray appearance, Codman triangle, osteosarcoma. Onion peel appearance, Ewing sarcoma. Osteosarcoma radioresistant, Ewing sarcoma radiosensitive. Okay, okay. And there is one more sarcoma to remember. That is chondrosarcoma. If you have a tumor arising from the pelvic flat bones in an adult, pelvic flat bones in an adult with popcorn-like appearance, think of chondrosarcoma. Chondrosarcoma. ठीक है, it is a misprint in the book, so don't get mistake. Chondrosarcoma, not chondroblastoma, chondrosarcoma, chondrosarcoma. Okay. Okay. There could be some benign lesions in the bone which they love asking in the NEET PG exam. So let's look at them. What do you think? Previous NEET PG image right in front of you. It can be asked in the upcoming FMG exam also. There is a bony outgrowth from the bone growing away from the joint. Diagnosis: exostosis, also called as osteochondroma. Don't get confused. If they show you a finger, a phalangeal lesion, well defined, then it is different. That is enchondroma. This is osteochondroma or exostosis, phalangeal well defined lesion, enchondroma. Osteochondroma, enchondroma. Okay. Osteochondromas are benign, but they can have a malignant change in the cartilage cap. That is why you saw this question last year in the IIMS exam. Osteochondromas, you need to do a MRI to look for cartilage cap thickness. If the cartilage cap thickness is more than 1.5 centimeter, consider doing a biopsy. Okay. Osteochondroma and chondroma. Okay. Now we make things more interesting. Okay. Now tell me, is there any disease in the lung? Is there any problem in the lung? Yes. Single or multiple? Multiple, bilateral, large size nodules, both the lungs, tells me it is a hematogenous spread happening. Appearance is cannonball, cannonball. Cause is metastasis, metastasis. And for lung diseases, always do CT scan. Don't forget. Lung diseases, CT scan. But don't forget, which lung cancer needs a MRI? Which lung cancer needs a MRI? Pancreas tumor. Because pancreas tumor is involving the apex, causes involvement of the brachial plexus, then you do MRI. Otherwise, all lung pathologies do a CT scan. These are cannonball metastasis in the lung. Okay. Super intelligent students. Okay, next question. But metastasis can also go to the bone, they can go to the liver, they can go to the brain. The common thing between them is the body parts are different. But imagine, once you know the secret, you are in the chamber of secrets in the Harry Potter. You know how to unlock it. You know, if the nodules are random and multiple both sides, it is hematogenous process. Okay, it is hematogenous metastasis in the pelvic bones, in the brain, in the liver. Okay, whenever you see pelvic bone osteoblastic metastasis, think of prostate cancer. Remember a term called as super scan. Super scan, beta, super scan. Because the metastasis in prostate cancer are osteoblastic, they take up all the isotope. So there is isotope uptake only in the bone, not in the soft tissue. That is called a super scan, seen in prostate cancer. Now look at the liver. Liver can have metastasis from colorectal cancer. Right lobe, left lobe, both are involved. And don't forget the brain. Brain can have metastasis, both sides, multiple. Most common location, gray white matter junction, previous NEET PG question. Most common location for cerebral metastasis is gray white matter junction. But if you notice, it is all the same actually. All the slides are having random nodules, both sides. Think of hematogenous metastasis. Then you don't think of a primary cancer. It is a cancer, but it is secondary. Okay? Some of you keep complaining and you keep saying, sir, bahut der ho gayi hai. Am I too late? Am I too late? I just wanted to remind you, it is never too late to start afresh. Okay? Imagine you can, with our current life expectancy, you might live up to 90 years of age, maybe 100, maybe 110, my dear boy and girl. Then, do you want to make decisions right now that you will regret for 90 more years of your life? No, you want to start now, stop regretting. I want you to meet this lady. This lady, old lady you can see, has started this business recently of making potlies. And she is exporting her potlies across the world. It is never too late to start. The man who started KFC, he started cooking burgers after retirement at the age of 68. And you are saying it is late. No, it is not late. Start now. Start with fire. Bring power. Make it happen. Okay. Make your teacher proud. And finally, before we go, we need to look at some emergencies, because a patient can come to emergency. Very important. Let us see. First question. Patient comes with breathlessness. Patient comes with breathlessness. Emergency. Look at the X-ray. What do you see? Patient comes with breathlessness to the emergency. Both of them are pulmonary edema. Both of them, fluid is in the lungs. Patient is breathlessness. Emergency patient. Which of them, tell me, is cardiac heart failure, which is ARDS? Tell me, beta, which of them is heart failure, which is ARDS? I am sure you can tell me. The first one is diffuse opacification of the lungs. Both the lungs are diffusely opacified. This is ARDS. In the second image, you can see a bat wing-like appearance. That is heart failure, left ventricular failure. Always remember, diffuse opacification is seen in ARDS, bat wing appearance is seen in cardiogenic pulmonary edema, in which pulmonary capillary wedge pressure is high. Okay? Done? Second question. Patient comes to emergency with breathlessness. सांस नहीं आ रहा, sir. Doctor साहब बताओ क्या लग रहा है? This thorax looks more black. It could be a pneumothorax. Prove it. Why it is pneumothorax? Below the pneumothorax, I can see a sharp line. Can you tell me what is this line? Anyone? This is the pleural margin of the collapsed lung. The mediastinum is pushed. The trachea is pushed. Visceral pleural line sign. Can you tell me what has happened? Can you tell me what has happened? This is pneumothorax. This is pneumothorax. I saw in the chat box somebody was asking, sir, reverse bat wing किसमें होता है? Reverse bat wing appearance is seen in chronic eosinophilic pneumonia, beta. Chronic eosinophilic pneumonia. Okay. Okay, done. Okay. Another patient with breathlessness in the emergency supine film. Another patient with breathlessness, supine film. What do you see? The CP sulcus appears very deep. CP sulcus appears deep. It is the deep sulcus sign. You saw it in the last year's inicet exam. It is the supine film sign of pneumothorax. Supine film sign of pneumothorax. Are you able to do it? Okay. Now, in patients with, the patient can come to emergency with trauma. And the first step you do in blunt abdominal trauma is fast. If you do a fast, this is liver, this is kidney. What do you see? What do you see in between? Blood. This is called as fast positive. If you see hemoperitoneum in a patient with fast, the fast is positive. Okay, my dear children, now tell me, all the children, please tell me. If the fast is positive and the patient is stable, what will you do? If the fast is positive, patient is stable, you will do a CECT. If the patient is unstable, there is no time for CT, go for exploratory laparotomy. Okay? Fast positive, stable patient, CECT, unstable patient, go for exploratory laparotomy. Next question. In fast, where do you keep the probe first? In fast, You keep the probe first in the subxiphoid area to look for a fluid in the pericardium. You want to look for cardiac tamponade. In fast, the probe is kept first around the, tell me, in the subxiphoid area. Very good. Now, two images. Please relax and tell me, this is your this year's NEET PG question. Most likely they are asking pneumothorax. Please tell me, on this M mode ultrasound, which is pneumothorax, which is not? Now, when you include the thorax also, it becomes extended fast. The first image has a seashore-like appearance. You can see a seashore-like appearance. This is normal. In the second image, you can see a barcode or a stratosphere appearance. Pneumothorax. Okay. So what was common in these emergencies? Most of the time the patient was breathless. Okay. Now let's look at another one. Another breathless patient. This particular patient is bedridden and breathless. Bedridden bhi hai. Oh, stasis, bedridden, breathless. What do you think? What do you think is coming here? Pulmonary embolism, a saddle-shaped embolus in your pulmonary artery. Okay. Now the questions are diagnosis, pulmonary embolism, investigation of choice. Investigation of choice, bhai, bol, bata. Investigation of choice, CT pulmonary angiogram, screening test, D-dimer, screening test, D-dimer, named signs, Westermarck sign, Hampton hump, Pala sign. Okay, Westermarck sign, Hampton hump, Pala sign. This is pulmonary embolism. Again, common thing, breathless patient. Question will be emergency breathlessness, bedridden. Okay. Now let's change the emergency to chest pain. Let us change the emergency to chest pain. I know you are not tired, okay? So don't give me any excuse. I know you are excited as I am. I am super excited whenever I'm teaching. And I promise you, I'll teach your son also. It's very, I want to do it. Recently was a very landmark moment for me. Recently we enrolled a student in our first year MBBS. And his papa was our student. Can you imagine? Okay, now tell me. Look at this. Patient with chest pain. What do you think? Patient with chest pain. What is your idea? Aortic dissection. Okay. Type. Stand for type A. Why? Why stand for type A? Why stand for type A? Because it is involving the ascending aorta. Management. Urgent surgical, because there is a risk of cardiac complications. Okay. Which of these two lumens is the false lumen? This is the false lumen. Why? False lumen should be larger, non-enhancing, can have cobweb-like appearance. So aortic dissection, chest pain, stand for type A, management urgent surgical, false lumen has cobweb sign, non-enhancing, larger size. Association Marfan syndrome. Okay. Now, investigation of choice for aortic dissection, CT angiogram. Investigation of choice, CT angiogram. If the patient is unstable, bedside transesophageal echocardiography is going to be done. If the patient is unstable, you cannot do CT, bedside transesophageal echocardiography will be diagnostic. Okay. People will come to emergency because of accidents. And you will read this word many times in NEET PG. patient is a patient of motor vehicle accident. Now, my question is, in a patient with road traffic accident, can you have a aortic rupture? Can the aorta rupture? If the aorta ruptures, where? Now remember, in our arch of aorta, at the level of subclavian artery, left subclavian artery, you have a ligament called as ligamentum arteriosum. So this ligamentum arteriosum is holding the aorta. When you have a road traffic accident, you go forward. The aorta goes forward and the ligament pulls you and it causes a tear at the site of insertion of ligamentous arteriosum. Very important question now. Tell me, what is the most common site of injury in the thoracic aorta? Insertion of ligamentum arteriosum. These patients after accident will have mediastinal widening on a X-ray. Investigation of choice, CT angiogram. X-ray will have mediastinal widening. Most common site of injury in thoracic aorta is insertion of ligamentum arteriosum. Okay. Next. Road traffic accident patient, beta. Road traffic accident. Nothing. Emergency with accident, beta. Get up. Accident patient has come. Okay, now tell me what has happened. On the CT scan in the spleen, you can see areas of enhancement. These enhancement is as bright as the aorta. What do you think? Name the sign and the significance and get into Central Institutes. Anyone? Name the sign. Contrast blush. This tells you that the arteries in the spleen are bleeding. They are leaking blood, leaking contrast material. It is looking as white as the aorta. It tells you that the active bleeding is happening. Conservative management may not help. This is called as contrast blush in the CT scan. Have you heard of this splenic trauma? Okay. One more. Suppose you have a patient with accident with hematuria, that is renal trauma. Renal trauma. Investigation of choice for renal trauma, CECT. Investigation of choice for renal trauma, CECT. Investigation of choice for renal trauma if the patient is unstable, single shot IVP. To look for functional status of the opposite kidney. We want to see the opposite kidney. Now I will show you a CT scan. This is the normal kidney. This is the injured kidney. Look at the CT. Imagine and tell me what has happened. If you notice carefully, you will be able to see that the kidney is not taking up the dye. Why not? Because this patient has a vascular pedicle injury. In renal trauma, if the renal vessels are cut off, there will be no enhancement in that kidney. This is how CT helps. Investigation of choice for renal trauma is CCT, unstable patient, single shot IVP to see the function of the opposite kidney. Okay. This time the patient comes to you with bladder trauma. Anyone, bladder trauma can be extraperitoneal, intraperitoneal. Intraperitoneal rupture is through the dome of the bladder with peritonitis. Extraperitoneal rupture, the dye will leak anterior to the bladder like a molar tooth. So what is the investigation of choice for bladder trauma? CT cystogram. CT cystogram. Molar tooth appearance, extraperitoneal. Dye leaking around the bowel loops. From the bladder, the dye has gone into the bowel, around the bowel, intraperitoneal rupture. Okay. Are you able to do it? Investigation of choice for bladder trauma, CT cystogram. Molar tooth appearance, extraperitoneal rupture. Dye leaking around the bowel loops, it has gone into the peritoneal cavity, intraperitoneal rupture. Where is the bladder? बेटा ये जहां फोलीज दिख रहा है बेटा, ये फोलीज यहां पे ब्लैडर है बेटा, है ना, डाई उससे बाहर निकल गई है, because it is ruptured anteriorly. We have done a CT cystogram. Okay, so I'm repeating it. So if you are, some of you might have, being exposed to the DAMS platform for the first time, but I want you to know now, do you see what you're missing out? You're not reading the usual things, you're not reading accidents. Very important to remember, there are two kinds of bladder ruptures. If the bladder is full and ruptures, and the dome ruptures, the urine goes into the peritoneum. So if I put dye in the bladder, and I see dye leaking into the peritoneal cavity, that is intraperitoneal rupture, these patients will have peritonitis. Extraperitoneal rupture is from the anterior wall, and the dye goes pre-vesical, like a molar tooth. That is called as extraperitoneal rupture. Okay, happy? Now, patient with head injury, ये तो नहीं भूलना भाई, head injury. भाई इमरजेंसी में आएगा, या तो पेट दर्द होगा, सांस नहीं आ रही होगी, चेस्ट पेन होगा, चोट लगेगी, है ना? Now tell me. Okay, now tell me, shape, biconvex, shape, biconvex, limited by. Why this hemorrhage is not able to cross these lines? What is it? Limited by sutures. Limited by sutures. Rupture of middle meningeal artery. Rupture of middle meningeal artery. Anatomical landmark. Middle meningeal artery enters the skull through foramen spinosum and passes near the pterion. Anatomical questions: foramen spinosum, pterion. Diagnosis: what other symptom? Lucid interval. Diagnosis: extradural hemorrhage, epidural hemorrhage, extradural, EDH. Okay, clear? Okay, next question. Now, why is the hemorrhage appearing dense? Hemorrhage on a CT scan appears hyperdense because it is clotted blood. The blood has clotted, that is why it is dense. Okay, keep it in mind. Now look at this image, beta. Now look at this image. A hemorrhage should be white because it has clotted blood. This patient has some dark areas. That means the patient is still bleeding. There is some unclotted blood which is yet to clot. Name the sign. Name the sign, beta. Name the sign. This is called as swirl sign. See the swirling arrow. Okay, see it again, beta. Swirl sign. Seen in active bleeding. Within a brain hematoma, if you see darker areas, that tells you that there is some active bleeding still happening. This hemorrhage is going to expand further. Okay. Okay, last year's NEET PG question. Shape. Can you see this hemorrhage overlying the brain parenchyma? Okay, shape. Everybody, shape. Shape. Concavo-convex. Shape. Concavo-convex. Limited by dural folds. This concavo-convex hemorrhage is limited by dural folds like falx and tentorium. Rupture of bridging veins. Rupture of bridging veins. Seen in old people, alcoholics. Don't forget, shaken baby, child abuse. Name the hemorrhage. Subdural. Name the hemorrhage. Subdural. Are you clear? Rupture of bridging veins. Now sometimes they trick you by saying even this patient has a concavo-convex subdural. But then why is this totally dark? Because after 4 weeks, the blood clot is liquefied and becomes like CSF. You can see in front of you, this is your chronic subdural hemorrhage. Chronic subdural hemorrhage. After 4 weeks, the clot liquefies. It is chronic. The first one was acute. This is chronic subdural hemorrhage. Okay. Now, I am sure you know you don't need any history here. Sure short question for NEET PG यार. मैं जा रहा हूँ बता दो बस. Sure short question है यार. I am sure you will tell me. हाँ? सोचो. Anyone? Look at it. Look at it. Okay, look at it. Sudden severe headache, neck rigidity, worst headache of his life, like the kind that has never happened before. Thunderclap headache. The answer is subarachnoid hemorrhage. Answer is subarachnoid hemorrhage. And if you have a spontaneous subarachnoid hemorrhage, we always think of ruptured berry aneurysm. Ruptured berry aneurysm, which is seen on a CT angiogram. Always remember this. Ruptured berry aneurysm, investigation of choice for cerebral aneurysm, CT angiogram. Screening, MR angiogram. And this is all how you see subarachnoid hemorrhage going into the CSF spaces. Okay? Okay. After a high-speed motor vehicle accident, if you see in your NEET PG a patient who is comatose, low GCS, always think of shearing injury to the brain. That is called as diffuse axonal injury. In these patients, CT scan may be normal. MRI is the investigation of choice. Most useful MRI sequence is SWI, susceptibility weighted MRI. Most common site of injury, gray white matter junction. Other sites, corpus callosum and midbrain. What am I talking about? Diffuse axonal injury. Always remember, very important question for NEET PG. You can't come back by doing this wrong. एक गलत करके मेरे पास मत आना भाई. High speed motor vehicle accident, shearing injury, comatose patient, low GCS, investigation of choice, MRI. Most common site of injury, gray white matter junction. Gray white matter junction. Okay? Okay, well done. Next question. बहुत सारे बच्चों ने बोला सर I am not able to identify angiograms. Let me help you in one slide. Okay? See one by one beta. Look at this image. What is the color of the bone? What is the color of the bone? White. You can see the blood vessel, but the bones are white. CT angiogram. CT angiogram. Okay? CT angiogram. Second image. You can see the blood vessels, but the bones are dark. That means it is not CT, it is MRI. And if you don't see the bones at all, only the blood vessel, that means you have removed the bones digitally. That is called as digital subtraction angiography, DSA. ठीक है, simple. Bones सफेद है तो CT है, dark है तो MRI है ही नहीं है तो DSA है. Okay. How do you identify the angiographies? CT angiogram, MR angiogram, DSA. Okay. And before I forget, I can see this in the chat room already. If on an angiogram, this is normal, but if you on an angiogram you see a puff of smoke appearance, you think of moya disease, moi. Okay. If you see puff of smoke appearance on an angiogram, moya disease, moi. Okay. Now, what do you think? Patient with stroke, what has happened? Hemorrhage. Why? Why do you think this patient has a brain hemorrhage? Why, beta? Tell me. Because of hypertension. Because of hypertension. Okay. And what is the most common site of hypertensive bleed? What is the most common site of hypertensive bleed? Putamen. Putamen. What are other sites of hypertensive bleed? Other sites of hypertensive bleed are basal ganglia, thalamus, pons, cerebellum. Basal ganglia, thalamus, pons, cerebellum. Okay, next question. Now suppose you see a brain hemorrhage which is not in the basal ganglia. Can you see this hemorrhage is involving the lobe? It is a lobar hematoma. So if you see a lobar hematoma in a child, think of AV malformation. If you see a lobar hematoma in an adult, anyone? Lobar hematoma in an adult, old person, amyloid angiopathy, cerebral amyloid angiopathy. What are you looking at? You can see a lobar hematoma. Hypertensive bleeds are usually in the basal ganglia. A lobar hematoma should make you think of unusual causes of parenchymal bleed. In a child, AVM. In an old person, amyloid angiopathy. Amyloid angiopathy. Okay. Now, we've seen the hemorrhages. We should see the stroke infarct part also. Name the sign. Anyone? Name the sign. I know you know it and you don't know it yet. I know you have the potential as a teacher. I know you can do it. Tell me now. Name the sign. Beta, tell me. In this image, you can see a dense, hyperdense MCA, hyperdense middle cerebral artery. What is this a sign of? This is the earliest CT sign of hyperacute infarction. Earliest CT sign of hyperacute infarction. Okay. Second question, beta. Second. What investigation is this which is showing you a brain infarct earliest? What investigation is this which is showing you a brain infarct earliest? This is asked multiple times in previous NEET PG exams. Can anyone tell me? The investigation is diffusion weighted MRI. Diffusion weighted MRI shows the brain infarct earliest. How early? As early as when the cells are swollen in the stage of cytotoxic edema, as early as 3 to 30 minutes of onset. As early as 3 to 30 minutes of onset. Okay. And I am now asking you a very tough question. Once in inicet, because I told you you will not stop till May. Once in inicet, they asked a question on apparent diffusion coefficient. Now tell me, a brain infarct, always remember, a brain infarct should be white on diffusion, dark on ADC. I will show you, beta. Remember this line. Potential question for the May inicet exam. inicet paper, write it down. They ask stroke every year. Okay, stroke to पूछते beta. Diffusion weighted MRI, infarct will be white, but the infarct will be dark on ADC image. This is a potential question. Bright on DWI, dark on ADC image. ADC stands for apparent diffusion coefficient image. Only for central institutes, beta. Only for central institutes. Another concept for central institutes. In a patient with stroke, we always first do NCCT. Why? Why do we do a CT first? To rule out hemorrhage. To rule out hemorrhage. If there is a hemorrhage, you will not do thrombolysis. If there is a hemorrhage, you will not do thrombolysis. But my question is, tell me, if there is no hemorrhage, what will you do next? INICET क्वेश्चन नवंबर 2022. टेल मी, अगर सीटी पे हेमरेज नहीं है तो अगला क्या करोगे? इस बॉक्स में क्या डालो? सीटी एंजियोग्राम. Then you will do a CT angiogram to see if it is a proximal large vessel occlusion. Okay. If the CT angiogram shows a large vessel occlusion, then you do a diffusion weighted MRI. This is the sequence: NCCT, CT angio, DWI. Okay. Previous INI-CT question. Okay. Done. Always remember, stroke is an important topic for your central exams as well as NEET PG. These patients will come to emergency with hemiplegia. Okay. Emergency is what we are talking about. Okay. Now see beta. Now try to see the CT scan with me. Okay. This CT scan shows a wedge-shaped hypodense area in the middle cerebral artery territory. Wedge-shaped hypodense area in the middle cerebral artery territory. What do you think? MCA stem occlusion. It is a large vessel occlusion, infarct. Okay. Large vessel occlusion. Can you see here? Large vessel getting wedge-shaped hypodense infarct, MCA territory. Okay. But sometimes we forget. What is the kind of stroke which is seen in women? In women, especially around pregnancy or who are taking oral contraceptives, they have a hypercoagulable state. Okay. If you have a hypercoagulable state, you can develop cerebral venous thrombosis. Okay. More common in women, you have venous thrombosis. And when you do a NCCT, the thrombosed vein looks like this. You just need to name the sign. Thrombosed vein, cerebral venous thrombosis on NCCT shows delta sign, delta sign. You will hear the same in ENT when they talk about ear infection causing sinus thrombosis. Okay. On CCT, empty delta sign. On CCT, empty delta sign. Investigation of choice for cerebral venous thrombosis, MR venogram. Investigation of choice for cerebral venous thrombosis, MR venogram. Okay. This is how it looks like. This is MR venogram. You can see the veins, superior sagittal sinus, the transverse sinuses. This is how they can ask you identify MR venogram in the exam. MR venogram. Okay. Now, I'm sure you can tell this. Every year it is asked in the NEET PG exam. I've already marked the finding. What do you see? You can see the gas below the diaphragm, pneumoperitoneum. The patient must be having bowel perforation. Okay. Pneumoperitoneum. Questions are, what is the best X-ray for the condition? What is the best X-ray? Chest X-ray erect. Best X-ray for pneumoperitoneum is chest X-ray erect. Now we have changed to patients who come to emergency with acute abdominal pain. Emergency में क्यों है? Chest pain है, पेट में दर्द है, सांस नहीं आ रही, ऐसा चोट लगी, accident हुआ है. So this patient has acute abdomen. You are suspecting bowel perforation. Best X-ray, chest X-ray erect. If the patient cannot stand up, what will you do? Previous inicet question, beta. If the patient cannot stand up, you need to do a left lateral decubitus. You need to do a left lateral decubitus. Can you name some signs? Okay, remember these. Wriggler sign, football sign, cupola sign, telltale triangle sign, falciform ligament sign, inverted V sign, inverted V sign. Now, sometimes you see last year in inicet they directly asked football sign seen in. In one of the NEET PG they asked telltale triangle seen in. These are all signs of pneumoperitoneum, inverted V sign, falciform ligament sign. Okay. If you see pneumoperitoneum on a CT scan, you will see gas below the anterior abdominal wall. If you have pneumoperitoneum on a CT scan, you will see gas below the anterior abdominal wall. Okay. Okay. Now, let's go further now. Let's see if you can answer better. Now, what do you see here? Acute abdomen. Don't forget, they can ask you bowel perforation, they can ask you bowel obstruction. Can you see centrally placed dilated bowel loops? Centrally placed dilated bowel loops with complete folds called as valvulae conniventis. What is your diagnosis? Small bowel obstruction. Small bowel obstruction. Okay. कहीं ऐसा ना होना बहुत ज्यादा पढ़ लें और कॉमन चीजें गलत कर दें. Intestinal obstruction. Okay. What is the best X-ray for intestinal obstruction? Best X-ray. X-ray abdomen supine. X-ray abdomen supine. Best X-ray. X-ray abdomen supine. What is the number of physiological air fluid levels in an adult? Up to 3. Up to 3 air fluid levels can be physiological. Investigation of choice. CECT. Investigation of choice for intestinal obstruction. CECT. What is the CT criteria of intestinal obstruction? CT criteria of intestinal obstruction is 369. Small bowel should be less than 3 centimeter. Large bowel 6 centimeter. Cecum 9 centimeter. Cecum ज़्यादा dilate हो सकता है. Cecum 9 centimeter के बाद obstructed बोलते हैं. Okay. CT criteria 369. 369. Okay. Common question beta. First one. What appearance do you see here? There is a dilated coffee bean shaped structure here. What do you think? Sigmoid volvulus. Coffee bean structure. Sigmoid volvulus. Sigmoid volvulus. Okay. What is in the second image? Second image is slightly tricky. Let's see if I can move a little bit more out. Okay. There is small bowel obstruction. There is small bowel obstruction. But there is a stone here and there are some air in the biliary tract. Okay. I'm putting them all together, beta. Small bowel obstruction, gallstone, pneumobilia, together called as regular striated seen in gallstone ileus. Regular striated seen in gallstone ileus. Okay. And I already told you, I've already told you, everybody loves stones. सबको stone पसंद है भाई. Stone नहीं पढ़ के जाएगा तो गड़बड़ हो जाएगी. एक बार देख ले भाई. Okay, please see. Everybody loves stones. पहला, staghorn calculus, multiple times asked in NEET PG. Second one is a bladder stone. You can see a stone in the urinary bladder, vesical calculus. Third one, right upper quadrant, multiple stones in the gallbladder, that is the gallstones. Everybody loves stones, don't forget, okay? Sometimes you may study too much. In the exam, they might just show you stones, okay? So I thought in one image, I will show you stones. Staghorn, vesical calculus, gallstones. Okay? And don't forget, some radiopaque things can be seen in children. Any time they say child comes to you in emergency, start thinking foreign body. Child in emergency, foreign body. Okay, first one. And you can see the value of DAMS DVT. We predicted almost every question that has been asked in the last year with our DVT. I'm sure we'll do it this time also. This is a coin in the esophagus. Coin in the esophagus, beta. Full, you can see in full circumference. But in the bottom image, there is an inner ring. This is not a coin. This is not a coin. This is a alkaline caustic battery. Okay. So the first one is coin. Second is battery. Okay. Second is battery. But, beta but. Okay. तीसरा देख ले बेटा. और वो बता दे क्या. The third one will be asked in the exam this time. They have asked the coin, they have asked the battery. अब बच क्या गया? बच्चे और क्या कर सकते हैं? Magnet, magnet, magnet. The third one is magnets. The metallic foreign bodies are magnets because they are sticking to each other. They can cause bowel perforation. Third one is magnets. Okay, are you clear? Okay. And child in emergency can come because of fractures. Okay, because of fractures. Usually trauma. But if you have a fracture without trauma, without history of clear-cut history of trauma, think of these things. The first image shows you multiple diaphyseal fractures in different stages of healing. Second image shows you a metaphyseal corner fracture. Okay. So remember, multiple diaphyseal fractures in different stages of healing, blue sclera, osteogenesis imperfecta. A corner fracture in the metaphysis is battered baby, pathognomic of child abuse, metaphyseal corner fracture. Can you do it? These are the fractures that they can have. These are non-accidental fractures that can be shown into you in your exam. In pediatric, there are 2-3 very favorite questions of the examiners. Okay, 2-3 they love in NEET PG particularly. This patient has a small posterior fossa. Because of the posterior fossa being small, his tonsil is herniating below the foramen magnum. He develops a syringomyelia in second decade of life. This is called as Chiari type 1 malformation. In the May inicet, I think they might ask you a question. Which type of Chiari malformation shows syringomyelia? Type 1. Type 1. Mark my words. Why am I am so confident? Because in the last year's inicet, they said, if you have spina bifida, can you see meningocele here, myelomeningocele from the baby's back? Spina bifida, yes. Then the skull will be shaped like a lemon and the cerebellum will be shaped like a banana. That is Chiari type 2. That is Chiari type 2. So if you ever see a question saying lemon shaped skull, banana shaped cerebellum, the answer will be association spina bifida, Chiari type 2. But if they say syringomyelia, then it is not Chiari type 2, it is type 1. Syringomyelia type 1. Okay, clear? Very, very important question for upcoming exams. Herniation can happen through the anterior abdominal wall as well. If you see abdominal content coming out from the midline, covered by peritoneal sac, associated with chromosomal abnormalities, omphalocele. If you see the content coming from the abdomen, covered by a peritoneal sac, with chromosomal abnormalities, it is omphalocele. If you see content coming out, from the abdomen, right paramedian, no peritoneal sac, associated bowel complication, gastroschisis. Okay, gastroschisis. Okay. Previous NEET PG question. If you have a posterior fossa cyst with agenesis of vermis, okay, put the chat box on fire बेटा, ये तो बता दो मुझे. वर्मिस नहीं है, पीछे सिस्ट है, ये तो है डैंडी वॉकर मैलफॉर्मेशन. posterior fossa cyst, agenesis of vermis, it is Dandy-Walker malformation. Okay. Clear? I think some of you missed this slide, so I thought I'll show it to you for some more time. Okay, now okay? The previous NEET PG question, beta. Midbrain shaped like this. Midbrain has a shape like this. What do you think that is called as the molar tooth sign? In which condition do we see molar tooth sign? Molar tooth sign is seen in Joubert syndrome. Joubert syndrome. Yeah, you might think it's slightly unusual, but NEET PG, they love it. Either Dandy-Walker, Chiari, Joubert's, inicet, NEET, they always ask this question. Okay. Okay. A child can come to you with some congenital heart disease. Congenital heart disease can have cyanosis. Now I want you to look at this cyanotic heart disease. Right-sided heart border is formed by right atrium. In this patient, the right atrium is pushing in this direction. What do you think? Right atrial enlargement, giving rise to a box-shaped heart. Why is the right atrium enlarged, giving rise to a box shape? Epstein's anomaly. Box-shaped heart, Epstein's anomaly. And another cyanotic heart disease is this. And I don't think you need me to tell you. Tell me the shape. All of you students from first MBBS onwards, you have been seeing this. Tell me, boot-shaped heart. Cyanotic heart disease, boot-shaped heart, tetralogy of Fallot. Tetralogy of Fallot. And the common thing between these two is, both of them will have oligemia in the lung fields. Lung field should have reduced vascularity. Okay. Last to last NEET PG exam, please see. What is the shape of the heart? Snowman, figure of 8. What is the sign? TAPVC. Snowman, figure of 8, TAPVC. While the second one is egg on side, which is uncorrected TGA. These two will also have cyanosis. But the common thing will be, they will be cyanosis with plethora. NEET PG question. Now are you clear? टॉफ और एब्स्टीन्स में साइनोसिस के साथ ओलिगीमिया है. TAPVC, TGA, cyanosis with plethora, short question for NEET PG. They love it. Okay. You can't miss this, beta. TAPVC and TGA are cyanotic heart disease with increased vascularity in the lung. Plethora. Okay. Pediatric patient comes to you with this. I'm sure you know this. This image I showed in the last DVT. This year it was asked in the FMG exam recently. What do you think this is? Both the kidneys are fused. What do you think? Horseshoe kidney. Investigation of choice. CECT. Both the kidneys are fused. CECT. But look at the second image. Okay. Let's relax. Enjoy the poetry that is going on in the medicine which we never saw. Try to enjoy the poetry, beta. If you have a IgG4 related problem leading to fibrosis in the retroperitoneum, the ureters will be pulled close to each other. Can you see here? The ureters are going close to each other. Okay. So what is happening? These are your kidneys and the ureters have to go close to each other. Just like the shapely waist of a maiden. This is called as the maiden waist deformity seen in retroperitoneal fibrosis. Maiden waist deformity, retroperitoneal fibrosis. I can see all the boys in the chat room are already answering. Maiden waist appearance, retroperitoneal fibrosis, IgG4 related disease. Okay. Two images, IVP images, favorite of NEET PG. First one shows fish hook appearance in the right ureter. What do you think? Retrocaval ureter. Retrocaval ureter. Second one shows a adder head appearance. Adder head appearance. Cobra head appearance. What do you think? Congenital dilatation of the ureter. What is the answer? Uretrocele. Adder head appearance, uretrocele. Fish hook appearance of right ureter is retrocaval ureter. Okay. Before we end the class, we need to give respect to the last year's NEET PG paper. Last year's NEET PG paper was full of tuberculosis and HIV. I don't know why the students who were studying from multiple resources, they forgot reading HIV and TB. Because they were collecting so much PDF being circulated on Telegram, they forgot reading the double trouble called as TB HIV. So let's give some respect to these two before we go. Okay. First one. Look at this image. HIV positive patient has a ring lesion with eccentric target. HIV positive patient shows a ring lesion with eccentric target. What do you think? हाँ बच्चे, HIV मरीज है, रिंग लीजन है, एसेंट्रिक टारगेट है. व्हाट डू यू थिंक? ये नहीं छोड़ के जाएंगे भाई, HIV छोड़ दिया तो गड़बड़ हो जाएगा ना. टॉक्सोप्लाज्मोसिस. HIV positive with ring lesion, eccentric target, toxoplasma. Okay. Second question. HIV positive patient, white matter disease, but non-enhancing. White matter disease, but not enhancing. That means it is not a bacterial, something viral going on. The problem is intracellular. This is PMLE. HIV positive patient with white matter abnormalities, intracellular inclusions in the oligodendrocytes, non-enhancing lesions. Remember, they are talking about progressive multifocal leukoencephalopathy. Okay. One more interesting question. Pardon me, but I am always trying to best to go for all the usual things in the exam. Okay. And I'm betting on it. You go to America, you will not find anything better than what we are teaching you here in radiology here. Don't panic. Everything is being covered, beta. Soap bubble appearance in the basal ganglia. Multiple small cysts in the basal ganglia. HIV positive patient. Can you tell me? Soap bubble in the basal ganglia. HIV maris. Cryptococcal meningitis. Multiple cysts in the basal ganglia. Cryptococcal meningitis. Cryptococcal meningitis. Okay. Now, tell me. HIV maris. Reticular shadow, reticular opacities. Pneumatocele formation. Can you see air-filled cystic spaces? Pneumatocele formation. Reticular opacities. HIV positive patient. Don't forget cotrimexazole, pneumocystis jirovecii pneumonia. Pneumocystis jirovecii pneumonia. HIV नहीं पढ़ के गए, बाकी पढ़ लिया, ये तो गलत हो गया. TB नहीं पढ़ा तो कहां जा रहे थे, है ना? Clear? Okay. TB now. Primary TB leads to Ghon's complex. Ghon's complex will have lymph nodes. Tubercular lymph nodes are rim enhancing. Do you see? Only the periphery of the lymph node is enhancing. The center is necrotic. Center is necrotic. What do you think? Because these are tubercular lymph nodes. Tubercular lymph nodes are rim enhancing and can be matted. Rim enhancing matted lymph nodes. Primary TB. Okay, primary TB. Secondary TB, you will have immune response. So secondary TB will show ring-like thing. What is this? Cavitation. Okay. Primary TB, rim enhancing matted lymph nodes. Secondary TB, cavitation. Okay. If TB shows hematogenous dissemination, you will see millet seeds, small millet seeds, 2 to 3 millimeter nodules in the lung parenchyma. Miliary TB, hematogenous spread. But don't forget, TB can spread via the endobronchial route as well. If the TB spreads along the endobronchial route, it looks like a tree which is budding. That is called as tree in bud sign. Can you mark it for me? Are you able to do it or not? Let me know, beta. Hematogenous spread of TB, miliary, endobronchial spread, tree in bud appearance. TB nahi chhod ke jana bhai. Okay. Common things are commonly asked. 80% of your paper will be from 20% of the topics, and all those 20% topics are there in your DVT book. है ना, यही पढ़ना है बाद में, ठीक है, डन। चलो आगे आते, टीबी से मिमिक देख लेते हैं, मिमिक। You are able to see 2 lymph nodes in the chest. Symmetry does not go in favor of infection. Now I have to think it is sarcoidosis, symmetrical hilar lymph nodes. On gallium scan, don't forget panda and lambda sign. On gallium scan, panda, lambda sign, sarcoidosis. Okay. TB, don't forget TB can be in the bowel. In bowel, TB affects the ileocecal junction. So it leads to chronic inflammation in the cecum, ileum. They get fibrosed and contracted. Ileocecal tuberculosis. Contracted cecum, contracted ileum, bowel tuberculosis. Investigation of choice. Investigation of choice for bowel TB is CT enterography. Investigation of choice, CT enterography. Okay, CT enterography. Okay. TB can affect the spine because vertebrae are very vascular. Hematogenous infection in the spine. Port spine. Most common pattern of port spine, paradiscal. Most common pattern of spine, port spine, paradiscal. Investigation of choice, MRI. Investigation of choice, MRI. If from the port spine abscess tracks along the muscle, cold abscess, that is Swas abscess, this patient will have flexion deformity of the hip. Flexion deformity of the hip. Okay. Then have you seen TB all over the body? You know, it's my, I always want to, you see the how tubercular bacilli can go into multiple systems. It can go into the kidney, cause putti kidney. It can go into the fallopian tube, cause infertility. Do you forget that? Many doctor females have genital tuberculosis, and that is a very risk factor. You need to be careful, beta. See this beaded appearance of the fallopian tube. And golf club tobacco pouch, very important cause of infertility, tuberculosis. Okay, so tuberculosis can be genital, can lead to fallopian duct obstruction. But if you go back, you will find it is all chronic inflammatory changes causing fibrosis and scarring and obstruction. Clear? Okay. TB can be associated with the occupational lung disease. Can you tell me an occupational lung disease in which you have upper lobe fibrosis with eggshell calcification of the lymph nodes? TB can be associated with upper lobe fibrosis. Which disease am I talking about? Silicosis. Eggshell calcification. Silicosis. Silicosis. And a tubercular cavity can have a superimposed fungal colonization, which is called as aspergilloma, and the sign on X-ray is called as Monod sign. Aspergilloma, Monod sign. Are you convinced that we have covered a lot of ground? Yes, but don't forget there are a few more things to be seen, miscellaneous. Okay, very fast. Very fast. I want you to see this miscellaneous condition. Please see. Identify the investigation. This is a thyroid ultrasound. Possible question for your NEET PG. Thyroid ultrasound. On thyroid ultrasound, how do you tell if a nodule is benign or malignant? We use a score, TIRADS. On thyroid ultrasound, we use a score called as TIRADS, which is based on composition, echogenicity, echogenic foci, shape, margins. Composition, echogenicity, echogenic foci, shape, margins. Okay. These are the components of TIRADS. Again, a possible question in your NEET PG. Okay. Miscellaneous. If a patient who is hyperthyroid looks like this on a thyroid scan, what do you think? Hyperthyroid patient Increased uptake in the thyroid scan. What is this? Graves' disease. Graves' disease. And if you see reduced uptake, thyroiditis. Thyroiditis. If you see multiple hot nodules, toxic multinodular goiter. And if you see single hot nodule, toxic adenoma, all of them will be hyperthyroid. All of them will be hyperthyroid in the question. You need to look at the image to make a diagnosis. And don't forget, before we go, don't forget the PET scan. This is a CT scan, PET scan, but the third image is a previous NEET PG image, PET CT. Where do we use PET CT? PET CT or PET scan uses 18-fluorodeoxyglucose, FDG. It is used for cancer staging, mainly to look for distant metastasis. It is based on a concept that the cancer cells exhibit Warburg effect, are glucose hungry, used for distant metastasis. PET CT, always remember. Okay, and before we end the class today, before I go, I thought I'll show you a tunnel. The tunnel is dark, but you have the fire in your hand or you have the fire in your belly. Tunnel of your life is sometimes it is dark. It is not easy. It's not going to be easy. I'm telling you, it's not going to be easy. Journey is not going to be easy. It was not easy for me. It is still not easy for me. But if you remember, this is a very important line. When I was very young, I was talking to someone and telling what do I want to do in my life. He said, you have fire in the belly. That word stuck with me. And today I'm telling you, if you have the fire inside, everything is possible. It is about having the fire in the belly. And if you have the fire in your belly, then you become like Saurav Ganguly, Dada, my favorite cricketer. This is Dada in London, in Lords. Remember, cold weather. You can't take off your shirt unless you have fire in the belly. After beating British in their own soil, Dada took out his shirt and said, yes, that is fire in the belly. Do you have the fire inside of you? If you have it, make it happen. The limit is not in the sky. The limit is in your mind. It is not in the sky. And don't forget the punchline that we always say, अपना टाइम आएगा, आएगा नहीं. कैसे नहीं आएगा? क्योंकि अपन उसे खुद लेके आएगा. अपना टाइम अपन खुद लाएगा. I wish you all the best. Keep rocking and I look forward to meeting you here in this studio for our interview in future. God bless you.